Good morning, everyone. Thank you for joining Shield Connect. And today webinar is conducted by Vijayawada Obstetric and Gynecological Society, FOXY, on Gynecology Workshop. So let me give an introduction of Dr. Shaileja Naluri. So ma'am is a Deputy Civil Surgeon in Insurance Medical Services in Vijayawada. Ma'am has graduated from Osmania Medical College, Hyderabad, and did MS from Gandhi Medical College. And ma'am is secretary of VOGS and treasurer of Vijayawada chapter of Indian Menopause Society. Ma'am has delivered lectures at IMA Vijayawada and Yuva Foxy South Zone 2018, and in the organizing team of first annual APCOG at Vijayawada, and in the organizing team of Yuva Foxy South Zone 2018. The field of interest is PCO and high risk obstetrics. So, ma'am, I hand over the session to you, ma'am, and thank you for joining today with Shield Connect.
Thank you for that kind introduction, Nishan. Good morning, everyone, and I welcome you all to this academic bonanza, which is for the second time in this year being organized by Dr. Sadhana Gupta from Gorakhpur. And let me tell you that she is contesting for the FOXY president this year elections. And we had an academic feast in August when she conducted an obstetric workshop. Now we are gearing up for this gynec academic bonanza. I hand over to Dr. Sadhana Gupta to Dr. R.S. Ramadevi garu. Today, our President, Dr. Geeta Devi, has just landed from USA. So I requested past President and founder President of EPOX, Dr. R.S. Ramadevi garu, to give her opening remarks. I hand over to Dr. R.S. Ramadevi garu for her opening remarks.
Thank you, Shailaja. Very good morning to all of you. Today's topics are very interesting topics. And our chief guest, Dr. P.C. Mahapatra, past President FOXY, excellent speaker, eminent surgeon, above all, a wonderful human being. Welcome, sir, to this academic meeting. Dr. Sharda Jain, Secretary General of Delhi Gynecologist Forum. Dr. Ambuja Garu, President, Indian Menopausal Society. Dr. Sadhana Gupta, FOXY representative of CEFOC. Of course, Dr. Geeta Devi, she has to arrive. And the chairpersons, all the chairpersons, eminent speakers, very nice, very welcome to this wonderful program. Because usually we conduct many obstetric workshops. Whereas gynec workshops, of course, we had vaginal surgeries workshops over. But this gynecological workshop is definitely very important. And today's topics are very important. Solving Adnexal masses enigma, optimizing medical management. Once you think, come across a fibroid, we plan for surgery, myomectomy. So in which cases we have to plan or we have to give medical treatment, that is very important. Nowadays, because of the medical management of the fibroids, not only that endometriosis, whenever we see endometriosis, we used to plan for cystectomy, laparoscopy, diagnostic, so many things we used to plan. So that is not the case in present scenario. And urinary incontinence also very important. And panel AUB. And it is very common in the very, very most important, especially in adolescents. This AUB panel discussion is very, very important. And safe surgical strike in gynecology. This is a new word or maybe very important coined word. And infertility and adolescence. Because these two places, this surgical strike, where we have to do, where we have not to postpone the surgery. So these are very important thing and very eminent speakers. And all the speakers, we welcome you to this Vijayawada Obstetric Society. And we are very happy to see all of you. Thank you very much. Now let us proceed for the academic meeting.
Now I invite Dr. Sadhana Gupta from Gorakhpur Society, founder president of ISOPAR chapter of Gorakhpur, to introduce our chief guest and guests of honor and say a few words about them.
Thank you, Shailja, and thank you, Dr. Ramadevi. And once again, a very good morning. And today is the martyr day of Mahatma Gandhi, and we all are there for a very important academic deliberation, which will, I think, all the speaker and all the topic which will deal to the issues for the common person and how we can do best. So with all that tribute to our father of nation, and it is our pleasure to introduce Dr. P.C. Mahapatra. Perhaps he could not able to meet, but he is a, like we say in Foxy, is a synonym of Jagannath Ji. And whenever we see his face, his smile, we feel blessed with the blessing of Jagannath Ji. And he is senior obstetrician and gynecologist, Nobe. He is teachers of teachers, has been president of Foxy and president of IMA in past, but he is a very loud and clear and a conscious voice in our federation. And he has guided and mentored a generation of ops gynae, and with the human touch, with the psychological touch. So he has sent his best wishes to program. He is always with us with his guidance and the mentoring, and we are very pleased that he has sent the blessing and the good wishes to our program. So thank you. And Dr. May I have? Yes. So it is a pleasure to introduce to what we can say legendary and the leaders in Ops and Gynae, Dr. Sharda Jain, who is a founder and secretary general of Delhi Gynecologist Forum. And actually for the leader like Sharda Jain, Dr. Sharda Jain, the CV actually doesn't speak. They are their CV. When they speak, we know what they are speaking, how they are inspiring and motivating each one of us who listened to them, who followed them. So she has been director she is Life Care Center and Life Care IVF director, has done a lot of academic accreditation to her credit. Faculty for 2 decades at PGIMS, Bijmer, Chandigarh and Lady Hardinge Medical College, founder and secretary general of Delhi Gynecologist Forum. Member and expert OB-GYN in ethical committee of MCI from 2018 to 20, and again in National Medical Council from 2021 to 2023. So she is our voice for many, many things in COVID, how the doctor should be compensated, so many voice. She is a clear voice for the rights and duties of doctor. Decorated by Lifetime Achievement Award and Living Legend Award, which she is by many prestigious body. And her passion is teaching and safety of doctors and creating medical legal awareness. We are really honored to have you, madam, with us in today morning. Kindly bless us and say a few words of inspiration.
Great good morning to all of you. I bring greetings from Delhi Gynecologist Forum, and my special greetings in the form of multiple bouquets I get from my colleagues for Dr. Sadhana Gupta, who is fighting for a presidential election. And this is all wishes her for a great success she should have in this presidential election. And my big salute to the organizing team of today's academic activity, which is focused on wide spectrum of gynecology. We all know that the medicine is really fast evolving. The pace of change has been rather fast. And what we read as postgraduate ourselves, I think is become pretty irrelevant. Example is, during our post-graduation, endometriosis was almost unknown. And now it has become so important that, both at the national fora and at the international forums, there are special subcommittees focusing on endometriosis itself. I find stalwarts of today's program are going to talk and share the experience and will do justice to the various topics. As far as AUB is concerned, is my very pet subject. Again, audience will see how the panelists will share the new knowledge and approaches in their clinical care, how they should handle it. Although the surgical skills remain same with open and minimal invasive surgery, but in the new time have changed. The old guards who had been old guards on the open surgery have taken a back seat. And unless they had decided, to gain the newest skills. And I think, I'm very happy that I'm a part of this particular academic meet. And I again wish great success and great wishes as far as Dr. Sadhana is concerned for her presidential election. So with that particular greetings, thank you very much for making a part of it.
Thank you, madam, for your kind words and the word of wisdom. We are really honored to have you. And it is again a moment of pride and pleasure to introduce Dr. Ambuja Charonar. And she is a very kind person, very compassionate person. And at present, she is President Indian Menopause Society. She is Research Committee Chairperson for SEPHOMS 2021 to 2023. Retired professor and head of the department, Osmania Medical College, Hyderabad, visiting professor, Savita University, Chennai from 2019 till date. All India Vice President of Family Planning Association of India, faculty and resource person for the National Board of Examination from 2001 to till date. Treasurer Society of Obstetric Medicine in India, peer reviewer journal for the Journal of Gynecology India, Journal of Midlife Health, and MRIMS Journal of Health Science. She is consultant editor, JK Science, Journal of Medical Education and Research, and undergraduate and postgraduate examiner to various medical universities. Dr. Ambuja is a person of knowledge, and she has been so active in every program which is related to our national health priorities, be it a obstetrical hemorrhage, be it a menopausal issue. And we are really privileged to have Dr. Ambuja with us from Hyderabad. And we request you to say few words and your words of inspiration to all of us.
Thank you. Thank you very much, Sadhana, for your kind words. It's an honor for me to be amongst you all for this program. Am I audible?
You are audible.
Yes, ma'am.
Yeah. I bring greetings from Indian Menopause Society. And this is a very great program. And having a workshop of gynec workshop is really great. Always we'll have the obstetric workshops, hands-on training, applying the forceps, doing this and that. Of course, obstetrics has gone down nowadays. It's only the gynec which is taking up more. We need workshops of this type always. As Dr. Sharda Jain said, in our days, we didn't read much about the endometriosis. It was only a part of it in Shaw, it was mentioned, but now it is the huge amount of knowledge we have got in in endometriosis, DUB, you take all the things. And we should never forget, even though science is advanced, about the prolapse is still existing. To talk about the prolapse, none other than Dr. Hara Patnaik, my younger brother, is here. And all the topics are so well chosen. They are of importance of today's. Really, I feel honored to be here. My greetings and best wishes to all the organizers and all the teachers who are all doyens in gynecology field. And above all, my sincere namaste to Madam Rama Devi, who is a mentor of almost all the teachers in Andhra Pradesh, combined Andhra Pradesh, and her services to the AP government is adorable. Today, so much of progress is being done in obstetrics. Of course, when she was a DME, it was the obstetrics which was in vogue. And she was responsible to get the operative, what can I say, all the operative field for the laparoscopy, hysteroscopy, all those things. She was responsible to get it to the Andhra Pradesh. Thank you, madam, for that progress, what you have done to the field of obstetrics and gynecology in Andhra Pradesh. The same way for all my students that are here, and I know each and every person here, Padmaja, Nagamani, Indira, all this, Shailaja, thanks to all of you. And I'm very happy. Thanks to Corona, I could meet you virtually. Susila, of course, now and then we will be talking on phone, but to meet virtually, really thanks to all of you. And Madam Sharda Jain, it is really, I am feeling great to meet you now and then. Maybe it would not have been possible physically if you would have arranged any of the conferences. Because of these virtual conferences, we are able to meet again. And today we are going to have the bonanza of Gynec workshop. And we are going to learn a lot, because the subject to learn is forever. As long as we are alive, there is every day, every moment, we are going to learn something or other, whether it is a junior most person or very senior person, whoever it is, the subject is for learning. And thanks for arranging such a great workshop, Sadhana, and all the best to you for your future endeavors and for your future elections. Thank you again for giving me the opportunity.
Thank you, madam, for all your wishes and guidance, and like recognizing your student and teacher, and how like we look forward to you people like Dr. Sharda and Dr. Ambuja, like for many things, not only in the science, but for the many things in the life, and how we should live life very carefully. Thank you very much. And with all the inspiration and the by wisdom words from our guest and chief guest and guest of honor, we request Shelja to continue with the scientific session.
Yeah, going ahead with the first session, madam. I'm introducing the chairpersons, Dr. Susila. Can I have Dr. Susila's slide, please? Yeah, Dr. Susila Pinnamaneni is the Vice President, Vijayawada OBG Society, Secretary, Vijayawada Menopause Society. He is a member and the South Zone Coordinator for the MTP Committee, FOXY, Consultant Obstetrician and Gynecologist presently at Lata Super Specialities, Vijayawada, and Samatha Multi Specialities, Mangalgiri. She was awarded first prize for Best Photography of Indoor and Outdoor Plants conducted by FOXY and World Environment Day celebrations in 2020. Welcome, Susila Madam. Indira Madam, slide please. Dr. Indira is presently the HOD and Professor in OBGYN Department in Kurnool Medical College since the last 7 years. He was my teacher when I was doing my post-graduation in Gandhi Medical College, Hyderabad. He has got many awards from collectors for best performance in Kurnool district in PPP. He is a very good teacher. Welcome, Indira Madam. I hand over to Dr. Susila to please introduce the speakers of first session.
Yeah. So, can you please share the CV of Dr. Dr. Patnaik? It's my pleasure to introduce Dr. H.P. Patnaik. He's a very familiar face, familiar orator, to say a great teacher. So he's been active since 1990 with FOXY and also a life member of many societies like IMS, ISOBAR, BISAR. And he is ex-Special Secretary, Health and Family Welfare, Odisha, ex-Director of Health Services and Director of Public Health, Odisha, President of Association of Obstetricians and Gynecologists 2015 to 16, past Vice President of FOXY 2019, and I know very well as President of Indian Menopausal Society since 2015, and he has been past President, Vice President of IMS and General Secretary of IMS. So as President, Vice President and Secretary, whole of office bearer, this thing he has been doing in Indian Menopausal Society. He has edited many books, and also he has many contributions to various chapters in various books and many publications. And to say he's a very good teacher. And sir, please update us on the pelvic organ prolapse today. Thank you, sir.
Thank you, madam, for those kind words, Dr. Susila, and I don't have any words to express. First of all, I must thank Dr. Sadhana Gupta for giving me this opportunity to speak to you all, particularly the Vijayawada Society, where Madam Rama Devi, the Doyen Obstetrician and Gynecologist, at the fortune to meet her in her residence with my guru, Dr. P.C. Mahapatra. Madam, namaskar. And I have visited Vijayawada Society during my election campaign. I must wish and I must say all my good wishes to Dr. Sadhana Gupta, who is running for President Foxy this time. Madam Sadhana, all the best to you and keep up your academic work whenever and wherever you go. My elder sister, Dr. Ambuza, I always respect and regard her, madam, as my elder sister, and she is the pathfinder to me, and the president of Indian Menopause Society. A lot many friends, including Queen Aditya from Calcutta, who is very, very nice, and Dr. Sailaja has told me and repeatedly she has asked for me this Madam Sarada Jain, the legendary personality and legendary figure and a great teacher. And I have my hearts up to her, my salute to her. With these words, I wish all the best and my regards to all these faculties and speakers today. And I have been assigned the task of speaking on uterovaginal prolapse. Are you able to see the slide? Are you able to see the slide?
Yes.
Yes, sir.
Yes, sir.
Yes,
So, I bring the blessings of Lord Jagannath. You know, during Corona time, the temple is closed, but Lord is always there to bless you all. And the good news is that from 1st of February, the temple will be again reopened after the crisis of Corona is gone. I hope the Lord will bless us all for all our good endeavors. I have been given a work of pelvic of prolapse, the update. See, this is the oldest of the topic which we read in our undergraduate days, in our postgraduate days, and day in and day out in our practice. There are certain changes, certain updates which has taken place, which I will be speaking. And Madam Sailaja, please tell me 5 minutes before so that I will conclude accordingly. Well, the flow presentation will be what it means, whether prolapse is a subjective symptom or an objective symptom by the patient, what are the factors responsible like activating factor and aggravating factor, and we'll just go through the supports of the pelvic organ, the classification system, the older and the newer one, what preventive steps we will take not to have prolapse, and the rational treatment. I use the word rational treatment is the update. And finally, few lines on the controversies and consensus which we get. We all know that protrusion of uterus and other pelvic contents through the vagina along with the vaginal wall down, it is because of the loss of supports of the vaginal wall. This prolapse or protrusion occurs via naturalis. I'm sorry for the disturbances. I hope you will be able to hear me. So the factors which are responsible, the activating factor is the inherent weakness in the support of the uterus. You know, pregnancy and childbirth, even menopause and post-menopause, which are loss of estrogen and causes laxity of the ligaments. And iatrogenic is the post-surgical healed on surgery can add to prolapse. The aggravating factor, you all know that chronic cough, constipation, or a condition with great intra-abdominal pathology will cause mobility and asthenia are the aggravating factor. You all know. Sorry.
Some disturbance is coming, madam.
Tulika, please mute everybody. Tulika, mute everybody.
Yes, ma'am. Yes, ma'am.
Ma'am, everyone are muted, ma'am. I think so. It's from sir saying.
There are the supports of the uterus, as we know, that it's a ligamentary support, the fascial support, and the muscular support. And the fourth one, which we call as the hormonal support, is the biochemical support or the loss of estrogen in postmenopause causes deficiency of the support of the uterus. You know, D. Lancey has told there are 3 layers of support. The upper is the suspension, middle for the attachment, and lower for the fusion. So accordingly, we devise a classification system. The older system is depending on the anatomical sites. So we graded as mild, moderate, and severe according to the staging. It is very easy to define, but it is subjective, and there will be variation from person to person, and there will be lack of anatomical defect, and you cannot quantify the defects. So the traditional anatomic site of prolapse of classification is urethrocele. So the posterior part of the lower anterior wall, cystocele, uterovaginal prolapse. The term used to describe the prolapse of the uterus, cervix, and upper vaginal wall, enterocele and rectocele. So the older concept, older classification was first degree, second degree, third degree, and fourth degree. It was the Shaw and Malpass classification, which all of us till now and many of us till now are following. But it is very understandable for apical and central defect. But it lacks site specification, and anatomic landmark are two, the ischial spine and the hymen. So the update is that the update classification has been two. One is Walden-Walker halfway system and POPQ. I'm not going to the detail, but what I want to say that Walden-Walker is user-friendly, easy to record, maximize the amount of detail that can be recorded in a brief space, lacks site-specific defect, and lacks quantification. So there are 6 defined sites in the vagina. The extent of the prolapse will be -0 to -0 to 4, and reference point will be say ischial spine and hymen. But the perineum, it is a graded difficulty as perineal tears occur. But the strength of levator contraction can be assigned from 0 to 4. So this is what the Walden-Walker hyphen halfway classification. We come to the most recent, what we call POPQ classification. Why POPQ came? Because standardization of terminology, International Continent Society, AUGS, and SGS, they joined together, and then there is a need for quantification of the prolapse, and that it should be site specific, and it should be assessed objectively, and better communication and understandable, and measurement will be rather than arbitrary, we have fixed measurement. So if you quantify on POPQ, so that anybody can understand, but the problem is that it is more scientific, reproducible, but it appears more complex. So many of the clinicians do not really practice POPQ classification, and it has really become only stored as academic. So it is easy to understand and difficult to practice, or difficult to understand or easy to practice, I will also say. The reference point will be 2 anterior, 2 posterior, 2 apical, and the measurement will be negative, proximal to hymen, positive, distal to hymen. 3 distinct measurement, GH, PB, and T. I am not going to say that because it's too complex and take time. The measurements are done in centimeter. Hymen is the fixed point of reference. Plane 0 of the hymen defined as 0. Above is negative in number, below is positive number. So accordingly, old and new, we have classified as stage 0, no prolapse. Stage 1, most distal portion more than 1 centimeter above the level of the hymen. Stage 2, it is less than 1 centimeter proximal to the distal plane of hymen. Stage 3, more than 1 centimeter below the plane of hymen. And stage 4. So now with this classification, we do the examination of the uterus, protrusion of the vaginal wall during straining. So traditional causes, traction cause no further descent. If you do it, and its subjects confirm the size of the prolapse. He tells that while I strain, while I cough, or while I stand, it comes out. But while I lie down, it goes. And others say that when I come stand or sleep or lie down, it is remaining always outside. So that is what. So most important thing is that position of the patient, whether in standing position, whether the lithotomy position or lateral dorsal position, and the type of specula. Some use single-braided specula, some use beam specula, some use Cusco specula. Every speculum examination has its own advantages and disadvantages. And examination during cupping and studying, we always say that bladder should be empty while examination. But if you is bladder full, does it really affect? So method of quantitative measurement has to be done by this. How to prevent prolapse? So we know that pregnancy and childbirth, vaginal birth, as told by multiparity or rapid succession of pregnancy, and labor management, mismanagement during labor, even third stage of labor, we all know that cause prolapse subsequently. So what is important that she should not deliver so frequently. So if till number of vaginal deliveries are less, the chances of prolapse will be less. So second thing is that you must manage the second stage of labor, cut short the second stage of labor, and during delivery, should the pelvic floor or perineal tear or episiotomy should be approached properly so that the vaginal tone or muscular tone is maintained. And third is, do not use undue traction during delivery of the patient. These are the things which we all know. And following that, we should be rehabilitation, nutrition, and pelvic floor exercise. And menopause and postmenopause, Madam Ambuja is promoting this, that late our postmenopausal women who are devoid of estrogen and hormones should not have. So they should do exercise, Kegel's exercise, using a vaginal cone, which will help. So second thing is that iatrogenic cause. You see, during surgical procedure, recognition of the pathology and tackling the pathology is important. So ill-formed surgery, ill-done surgery can cause vault prolapse subsequently. So apical suspension, angle of the vault or the uterosacral or cardinal ligament. What do? You can do a McCall's scaldoplasty, a sacrospinous fixation, or uterosacral suspension. So coming to the treatment, I am going very quickly. So first of all, expectant, whether the patient has a symptom or not. If you see, she tells that I am having a deficiency or difficulty, but there is no prolapse or no protrusion or no descent, you can assure that you are under observation. We will see you later. Non-surgical, when you use a pessary, vaginal aesthetic procedure and physiotherapy, which I have already told. And you know, when you use pessary, elderly lady following delivery, and all these things where their people are not fit for surgery, and these things pessary can be used. And finally, the surgical management. So surgical management of prolapse, you all know the different types of surgery, what you do. But what is our surgical goal? This is the update. So the first of all, the anatomy should be restored. So that is the point number one. Maximizing the function, addressing the urinary and defecating problem. So this is more important where rectocele or cystocele are occurring and there is a large residual volume urine, so not able to defecate. So these things should be addressed during a surgery. Promoting fertility potential if she is in the childbearing period and nulliparous prolapse. So this is the case where the fertility potential has to be done, and minimizing complication and preventing recurrence. So this is the goal of surgery. So what are the surgical modalities you will operate? Rational pre-op evaluation. The degree, the descent should be seen. The anterior compartment and posterior compartment and mid compartment should be assessed properly, and you decide what surgery should be done. Understanding the inherent factor is second thing. Correct understanding of the pelvic supports, clinical interpretation of altered anatomy. So what do you do after surgery? The anatomy, if it is altered, you must see that site-specific or quantification system has to be adopted, and planning for a rational modality. So in all these cases, you should avoid dogma, and you should see that what is good for the patient, that type of surgery has to be done. So this is a surgical skill and technique which is more important, and we always say that postoperative care will be required less if you do a good piece of surgery. So the surgical procedures will be restorative using endogenous support structure. So the end support structure, if they are retained or toned up, like what you do as a further gill repair, and you do these steps accordingly, that shortening of the cervix, anterior round ligament are tightened up, retrosacral ligament is cut, and this is the thing with restoration. Second thing is compensatory, attempt to replace the deficit support. If there is a deficiency, you will compensate with foreign material, or the third is obliterative. If you cannot restore or repose the normal anatomy, if you cannot compensate with a mesh or material, you can close it in a very, very elderly woman, so that if there is no space, there will be no descent. The surgical consensus is number one, is definitely a compartmental surgical approach, not a total that you do everything and close it. Identification of the defect and tissue loss and hemostasis should be minimal. Nowadays, the surgery opinion is that you should not sacrifice vaginal mucosa more than required. And many people are saying that vaginal mucosa should not be sacrificed at all. So instead, they use mesh and do it. And conclusion of mesh is already there. I am not going to that detail. Recognizing the surgical limit and plastic sense. You must have an aesthetic sense that the most important organ of a female body should have a restorative, a decent and good looking approach, and minimal invasion with maximal benefit. So what are the vaginal approach, anterior approach, paravaginal approach, posterior approach, apical approach, and ancillary procedure? I'll go to one by one in detail. So the second one is that you can also do with an abdominal approach. What do? You can lift the uterus with uterosacral suspension, or a abdominal sacrocolpopexy, or abdominal approach to posterior repair. Can be done. Earlier it was being done, and the traditional approach was cervicopexy, which we have seen in the training. The third one is the most recent one, the update, is the laparoscopic approach. So that what you are doing, opening the abdomen, you are able to do with a laparoscopic approach. But for that, you need training, you need equipment and setup, you need sutures, mesh, tuckers we are using, and the results can be compared with abdominal approach, with vaginal approach, and the complication in laparoscopy method are also less. So vaginal obliterative procedure, which will be done in surgically frail candidate when there is recurrence in elderly women and there is expected short life expectancy or limited activity in a very, very elderly and frail patient, vaginal obliterative procedure are being done. But the controversy in surgery remains, and the one is a vaginal and laparoscopic approach or an abdominal approach. Which one you should decide? Whether you do a vaginal approach, whether you do an abdominal approach, whether you do a laparoscopic approach. But the important is that what is good for the patient and what is the best for the patient should be offered, and with sufficient clinical surgical expertise. If I am not good at laparoscopy and I am good at vaginal and patient really require vaginal surgery, I will do it vaginally. If she needs laparoscopy approach, if I don't do it, I can refer to an expert for that. So second thing is that use of mesh and autologous tissue. Earlier, the procedure of apogee and perigee were being promoted by AUGA and other society, but finally there is a lot of mesh complication occurred, and they tell that mesh has occurred. So mesh is no longer being used, but for apical suspension, the controversy is still there. So there is a thing is that wall prolapse, whether you do a sacrospinous fixation or a uterosacral suspension. You do a lot of uterosacral suspension, so that this is little different, which I wanted to show. Madam, do I have time, or I will conclude with this, that pelvic organ prolapse is an entity which is known since time immemorial. So the first year when you entered into medical college, the first complaint a woman is either a prolapse or a fibroid. So known from time immemorial. Mortality is negligible, but it significantly morbidity, and it really affects the quality of life. The elderly woman, the old woman suffers a lot because of the prolapse, because of the decubitus ulcer, because of the dryness, because of other infection. seen in elderly, but distinct entirely entity in nulliparous woman in the reproductive period. That system has to be addressed, and nulliparous prolapse is a distinctive etiology which you should say. Iatrogenic, which you mean that post-surgical cases or a complication which is important, it is because either this surgery is ill-chosen or operation is not performed properly. So these are the causes of post-surgical bulge prolapse which may occur in many patients. Pathological pathogenesis is ill understood. Why it occurs? It is, but understanding the pelvic anatomy is still surrounded by myth. The suspension in the upper, attachment in the middle, and fusion is the lower is the rational concept. So classification and staging an enigma and a controversy. Ladies and gentlemen, with these few words, I think, madam, can I show a video or I'll conclude here if you say?
Go ahead, sir.
I have to stop here and I will go to my okay. I will show a Fibroid repair because there are a lot of slides are there. Can you see this? Hello? Are you able to see this?
Yes, sir.
Yes,
Okay.
sir.
It just came and went back. It's now blue.
Oh, God.
Yes, sir.
Ah,
Yes,
yes.
sir. Yes, sir.
So this is unedited, but what I want to say that in a reproductive period where uterine conservation is required, in those cases we do a further repair. So here the most important thing is that anterior colporrhaphy, posterior perineorrhaphy, shortening of the Mackender's ligament, and amputation of the cervix are the 4 steps preceding dilatation and curettage, which is being done to exclude malignancy. First of all, we take a triangular flap, what we are seeing, a V-shaped, inverted V-shaped incision is being taken. And here, what is more important is that if you get a proper line of cleavage, in those cases, the separation of the vaginal mucosa is easier. It splits like the pill, it's peeled up like this. And once you sacrifice the vaginal mucosa from the inverted V, you have to support or separate the uterus from the side of the vaginal wall. So from this side you go, and now that the bladder is mobilized up, cutting the uterovesical ligament. Once the bladder is moved up, then you go posteriorly, and the incision, which is the inverted V incision, is continued posteriorly, and with another V, and the posterior vaginal mucosa is separated. If you see, if you give a proper traction, the fascia will be stretched, and it is very easy to cut through this, and that so that your mucosa, vaginal mucosa, is separated from the posterior wall of the uterus and the cervix. And if you proceed like this, but you see that the Mackender's ligament will be visible gradually, and the uterus is gradually being separated from the posterior surface and the lower lateral surface. When this is done, you can see that the posterior peritoneum will be visible, and that opening of the posterior peritoneum is always done. And once this is done, you can separate it and you can see the cul-de-sac. And now it is further mobilized and bladder is being separated. We use single bladed speculum, which will be helpful to us instead of double bladed swim speculum. The peritoneum is separated, and you can see the fundus is popping out. Right. So I think it is a conventional prolapse. Yes. So in this case, so now that what we are doing is that the uterosacral ligament, Achilles ligament is clamped with Coccus forceps, and it is separated. Now that we always use Vicryl and followed by this, I think it is the conventional, well, so I think it is a conventional ward hysterectomy. I'm sorry, this is not, so that second, anyway, continue with this slide. The vessels, the uterine artery and the veins are clamped on the side, and the approach is that you should go very, very close to the uterus because the ureter crosses near the entry of the uterine artery. So when this is done, so the third clamp is put for the upper pedicle, and when that is done, from one side you can sit. If the hemostasis is done properly, if you are clamping properly, please allow some amount of stump which is good. I'm very sorry, it is not a further news repair, but a conventional ward hysterectomy which is being done. So with this, I think repair will be done after this. So give a pack, see the bleeding inside, and you can stitch the pedicles one after another. Normally, the upper pedicle we keep and we tie in the middle and bring it out, and then we separate. I think the end of the surgery, the closure. So normally we give a purse string suture to closure of the wall, and once the bladder is pushed, we can give lateral. This is what we do, a purse string suture. Then followed by this, then the bladder goes in, and you can give lateral stitches as the support, and the redundant vaginal mucosa is cut as less as possible, and the deficiency are closed, and the vaginal mucosa is repaired. So this is what I wanted to show, and I think I will stop here, or if you allow me, I can have another.
So thank you, sir, for the lecture. You have enlightened us on the POPQ quantification, prevention, management, and also the surgical goals. Thank you, sir. Sir, just a few questions to you. So does episiotomy prevent prolapse? And does instrumental delivery increase the chance of prolapse? And also, surgical approximation of episiotomy, does it really prevent prolapse?
Madam, I have told you one thing which you might have remembered, that restoration of the anatomy following delivery is very, very essential. So that is point. Your question was, does episiotomy help? Is the first and foremost is that there are two things you must remember. that the second stage of labor should not be unduly delayed. It has to go through the second stage of labor, but your work is that you should not unduly delay the second stage of labor, which will have a stress and a strain on the ligamentary support of the uterus. That is point number one. Second thing is that you must not use Predis maneuver, or you should not apply pressure on the fundus to deliver the baby, and Predis maneuver to deliver the placenta, or do undue traction of the placenta. These are the three deterrents. These are the three deterrents for subsequent prolapse in the woman. Second thing is that if second stage of labor is unduly delayed, then you can hasten it up by either a vacuum or a forceps. But before applying a vacuum or a forceps, you should take care that the tissues which has been severed or cut or excised by you are reposed properly in the due plane, so that the muscle will join with the muscle and the ligament will be support will be restored. If it is not done properly, if it is ill done, then there is a chance for subsequent prolapse. Second thing, many people say that episiotomy is not required because all vaginal delivery can be done without episiotomy. The answer is that it should not be a rigid compartment, that I will not do episiotomy at all. If you see the size of the head is bigger and the woman is having a problem, and you should give mediolateral episiotomy. It is not that in all cases I will also give mediolateral episiotomy, so the delivery and facilitated the delivery. These things should be kept in mind so that you will not tread upon one thing that dogmatically that I will do or I will not do it. That is my essence, that if it is really required, scientifically needed, and you feel that it is giving undue traction, undue pressure, so you can give episiotomy. There is no harm, there is no compartment feeling in these things that I must do or I should not do.
Thank you, sir. Any your experience on pessary, sir?
Madam, yes, of course, we are using pessary till date, even today. We are only using pessaries in elderly, frail lady who are unfit for surgery or who are unwilling for surgery. And second thing is that I had a patient long back. She had decubitus ulcer. We are using this glycerin acrifabin plaque. I don't think acrifabin available these days. What we do, give a pack, and still it comes out. And if the surgery is delayed for a certain time, we can use a pessary to delay the surgery and to heal the decubitus ulcer, which we normally do it as a routine practice.
Thank you so much, sir, for the talk and also for clearing us our doubts. So we move on to the next talk. Shailja, is it okay? Shall we move on to the second talk? Yeah.
Yes,
Thank you very much
Sadhana
for this
Gupta's
opportunity.
Yeah. So I'm very much happy to introduce Dr. Sadhana Gupta. So she is recipient of 9 gold medals in her MBBS, and also Dr. Naval Kishore Gold Medal for the best postgraduate student, and thrice Corion Award for best scientific research paper. So her academic career has been very bright, and she has also received thrice Dr. D.C. Datta Prize for best Foxy publication. So her achievements are the Foxy representative to CEPHOG, ICOG Governing Council member, corresponding editor to Journal of Obstetrics and Gynecology of India, and also for CEPHOG, Vice President Foxy 2016, Chairperson Foxy Safe Committee, Safe Motherhood Committee 2011 to 14. And she has conducted many workshops, a good organizer, and also a coordinator for the maternal mortality workshops and numerous publications. So I welcome you, madam. So she is going to talk on solving enigmas of adnexal masses. So madam, over to you.
Thank you, Dr. Sushila, for kind introduction. And once again, a very good morning. And let me share the slide. It is visible? Slides are visible?
Yes, ma'am.
It is full screen visible?
Yes, ma'am. Yes, ma'am. Go ahead, ma'am.
Solving enigma of adnexal mass after wonderful talk by Dr. P.C. Mahapatra. I will draw your attention for another Pandora box of the gynecology, and I bring greetings from all the wings of FOXY, ICOG, Journal, CEPHOG, whom I have served lifelong in various capacity. So, beautiful city of Vijayawada, we remember our father of nation, and who says, be someone's strength, be someone's inspiration, be someone's reason to never give up. And our guest of honor are actually our strength, and we have to reach every next level of our life, what the life puts us to us. So adnexal mass, where they are formed, it is ovary and fallopian tube and the surrounding mesosalpinx and mesoovarium, which is the condensation of connective tissue, and that are the part of broad ligament. From these tissues, adnexal mass emerge, and it is a Pandora box. It contributes to around 2 to 3% of all gynecological admission and 5 to 10% lifetime risk for women undergoing surgery for a suspected malignancy. And now, because of a very rampant use of ultrasound and a good machines, we are finding more and more adnexal masses in our practice. And how do we manage it? It is a real issue, and it tests your clinical acumenship, because you have to be very thorough whom we are dealing with, what is she, like BMI, comorbidities, what is her family history, what is her present and future reproductive desire. And in mind of patient as well as the clinician is always that this mass can be cumbersome due to transformation into malignancy. And there is always an issue that what is the effect of our medical management as well as the surgical on the hormonal status and the fertility status. So ultrasonography is the main modality which brings a lot of previously undetected adnexal mass to our notice. And the TVS and the TAS is the most important thing which we can not only diagnose, but we also characterize in quite a certainty that what is the nature of this adnexal mass. And important thing why it is important that how these adnexal mass, when we see on ultrasound, are reported, how well they are reported. It like polycystic ovaries seen as a cystic ovary, and the patient is coming it like a something cyst to remove. So how we report it, this is also very important. So we have a big number of differential diagnoses like to be crammed up in our examination or in our academic meets, but the important thing is that how we diagnose that what is troubling this person at this moment of time. And the important thing of science is that before we say something is abnormal, first understand normal. And these are the few pictures which is the normal, and it is a normal ovary but a different picture of the ovary because the patient is in a different phase of menstrual cycle. So one must be very careful that one we are seeing when we are like marking some adnexal mass or some cystic ovary or ovarian cyst, at what time the scan was done and what can be the report normal ovarian ultrasound pattern. So we have a very short lifespan on the earth, and for women it is around 25 years of the reproductive life, and I will go through very quickly to all the ages from the pediatric to the menopausal stage. In childhood or adolescent, when we see some adnexal mass, what are the issues to be like taken care of? The girl is having a mature reproductive system. With menstruation, the Mullerian anomalies are manifested. We want to preserve the future reproductive potential, and still there is a rare yet the chance of malignancy, and the girl can come as an emergency situation. So these are the few very, very common scenario which I say that a girl come with a like a little like 20 days overdue or 2 months overdue, and you do ultrasound and you find this sort of cyst. And though UPT pregnancy test we want to confirm, but the person and sometimes even doctor is very much worried but it is some sort of unruptured follicular cyst, and this is something physiological which need only withdrawal bleeding and only the watch. So this is very important that we see that what is normal and physiological, and reassure the girl and her parent that it is, we just have to follow up, and in some cases you can do the combined oral contraceptive. So this is again a list, what are the common adnexal mass in adolescent age, and I will go through few important ones which are clinically important. So functional corpus luteus cyst, follicular cyst, these are the functional cysts. Follicular cysts are usually benign, they never require surgical treatment, especially if they are less than 5 centimeter size. Corpus luteal cyst can sometimes give you a trouble because they can have the hemorrhage. Sometimes they present like a picture, like a torsion, and the girl is on the anticoagulant. They are particularly at the risk of rupture. So corpus luteal cyst, again, you have to be only watch and the symptomatic treatment, but sometimes they can mimic the picture of torsion or acute emergency. Paratubal cysts are also there, but another important thing, everything is not physiological also in adolescent, and the PID and the tubo-ovarian abscess and the hydrosalpinx. This is a common thing in a sexually active girl, and why this is important, not only we have to diagnose, we have to treat it fully so that patient does not have the tubal blockage and the tubal infertility. So this is very important, ultrasound diagnosis of the hydrosalpinx or the tubo-ovarian abscess, and how you can diagnose by seeing the patient clinical profile. She is having temperature, vaginal discharge, WBC on saline microscopy, ESR elevated, CRP elevated, and her sexual practices. So this is a very important health intervention which as a gynecologist we can do by patient coming with a mild pain in abdomen. You find it is a tubal hyperemia, hydrosalpinx, and we have to give full course of antibiotic and advise her for the safe sexual practices so that she does not land up into the tubal infertility. In our scenario, always and always we have to either exclude or confirm tuberculosis with supported investigation. Sometimes with antibiotic patient is not responding, and then we have to keep a high suspicion of genital tract tuberculosis. Mullerian anomalies, they become manifest during the time of menstruation, and the patient is having the blocking and the collection, all the bad collection of the blood in the female reproductive system due to vaginal agenesis, transverse vaginal septum. And when you have Mullerian anomalies, again, the patient needs surgery, and the patient needs surgery at the expert hand. There is not so that if we are not having that expertise, we should not do at our center. It should be given to the expert person, because the first surgery is the best time of the surgery. And if you do multiple surgery, definitely their reproductive potential going to be compromised. And when the time of surgery, this is very important that the patient should be emotionally mature prior to intervention. We can have tubal, paratubal, peri-inclusion cyst as well. And sometimes we say that sometimes we do surgery and we find there is a nothing cyst from the tube or the ovary, but it is a paratubal cyst, and it is the image is like anechoic cystic structure with pelvis adjacent to pelvic organ. And why it is a chronic inflammation, then adhesion develop, and the ovarian follicular fluid is entrapped in it. So you find a little bit vague picture, but they are also quite common. Endometrioma, we are going to have a wonderful talk on endometrioma, but they also present in adolescent, and the key issue is how we manage. I just want to give one point that surgery, laparoscopy for endometrioma in adolescent has to be balanced very, very carefully, because whatever surgery we do, there is a loss of ovarian reserve. So medical treatment, we have a very good option, and we should give that advantage and knowledge of a range of medical treatment, right from combined oral contraceptive to the new progesterone digesterone to, if needed, the other drug like the GnRH analog, if the BMD, but we have to keep a watch on the BMD and the other issue considering adolescent. Malignant potential. Now, this is very like a scary thing, and all gynecologists are worried for the like now this lesion is malignant or has the malignant potential. It is a rare or it is a uncommon, but still the ovarian cancer constitute to 1% of all pediatric cancer. And when you have that type of finding, we will go to the discussion how we can like suspect on ultrasound. We have to confirm it with the MRI and the tumor marker. And mind it is not CA125, which is common, which is useful in pediatric age group. It is LDH in case of this germinoma, choriocarcinoma, SCG, immature teratoma, CA99, and AFP in sinus tumor and embryonal carcinoma. So you don't become happy that you are doing CA125 and it is okay, because we have to consider other tumor marker in pediatric age population. Now, the fourth situation in adolescent, that the patient comes mild pain, you are doing conservatively, rightly, and suddenly patient comes with the acute pain in abdomen. And this is the time that we can do timely surgery once you have a clinical as well as ultrasound suspicion of the ovarian torsion. And this is very, very important. As I say, the hemorrhagic corpus luteal, sometimes it also mimic it. You just have to be very clinically alert and see ultrasound very, very carefully. The second thing which I want to say, that in torsion, one presume that there will be no ovarian flow, but it is not so, because the ovary has got the double vascular supply. And what is the pathognomic? I want to emphasize, it is a enlarged ovary, hyperechogenic ovary with peripheral displaced follicle. You can have whirlpool side, and when you have this, if the ovary is small, you can say that this torsion chance is very less. But if it is enlarged ovary with a whirlpool sign, you should always think torsion of the ovary. And when you have the vascular flow, be happy that you have the time to salvage the ovary, because when the total there is no vascularity, then sometimes you have to sacrifice ovary. But if there is vascular supply, you detort it, and always the ovarian function comes. And this is a paradigm shift in the management of the torsion of the ovary, because you do it. Initially, it was said that don't like de-twist because there may be thromboembolism, and this is very important, that de-twist, it become a normal blood flow and you can do cystectomy on the same sitting or in the next sitting. So this is a paradigm shift, and we could save around whatever surgery save. The recent paper that 92% of the distort ovary were saved with this approach. So in adolescent, we have to be very careful what is physiological, what is pathological, what need treatment, and what need only watchful expectancy. And when there is malignancy, always take the multidisciplinary approach, because we want to eradicate complete surgery and we want to retain the reproductive potential. So this is very, very important. Now coming to reproductive age, this is again a very common scenario, an infertile woman coming for a routine checkup, and you find such sort of a small dermoid. Now dermoid is something which as an obstetrician and gynecologist, we must be aware of it, because sometimes they are very small. So it is a fat fluid level, white wall appearance, dermoid mesh, and ultrasound can diagnose 99% of cases, especially the transvaginal ultrasound. You can pick up very small, even dermoid, and you have to like look in like that way, and always look in contralateral ovary, because around 7 to 15% are bilateral. Less, very small dermoid, you can go conservatively watch over, but it is the tumor which has to remove surgically, because medical treatment is not going to help. So don't prescribe COC and the other thing. Now this is again endometrioma with infertility, and I will not go into detail, but I will go to it, that it has a varied presentation on ultrasound. Sometimes it look like hemorrhagic corpus luteal. So sometimes it is a straight diagnosis. Sometimes you come to the diagnosis and CA125 is not diagnostic. for any malignant potential in premenopausal women. And my takeaway for infertility patient, that world is turning U-turn. And initially we had a see endometrioma, and in all workshop we always do cystectomy and aspiration, but now world has learned that the surgery approach to the endometriosis does not so good for the infertility, and you have to have a valid reason why you want to have surgery in infertile women. Long-standing down regulation followed by IVF is a reasonable approach. And if you think that in ART procedure it is getting difficulty in pickup, or you are not getting at all good follicle because of endometriosis, then you can consider surgery in good hands with a good technique, that is cystectomy. So this is very, very important, that what you do when you find endometriosis and how do you manage, and it requires patience, and how the patient respond to your initial treatment of ovulation induction and the other thing. In reproductive age, again, we can have all the physiological cysts, and again, the GERD, which have the hydrosalpinx in adolescent age. Now we can have a full-fledged tubovarian axis and the hydrosalpinx. And if it is creating tubal infertility, it is again an enigma that we should remove it, or we should do what. Prior to ART procedure, the salpingectomy is considered. Well, it has been found beneficial, but it has got its all pros and cons, and the patient acceptability, and sometimes tubal occlusion when it is technically demanded. In pregnancy also we can have adnexal mass, and in initial, so many people come, we do 6 to 8 week scan and we have got a corpus luteal cyst, which is a physiological cyst, but the patient is very much worried unless it is a big size or it is a having some real pain to the patient. So all type of adnexal mass you can have into the pregnancy, but you have to consider, you have to assess like in non-pregnant status, because when there is a malignant potential or when there is a torsion, the surgical intervention should be very prompt, as well as the approach should be safe for the fetus growing. So the second trimester is also always consider all type of surgeries, that is the best time to intervene, but it is very uncommon that we do it for the surgical intervention. We should be very careful about the simple corpus luteal cyst, hemorrhagic corpus luteal cyst, which usually resolve by the second trimester, by 10 to 12 weeks. If they disappear. With molar pregnancy, we can have theca luteal cyst, and with the ovulation induction, hyperstimulated ovary. Yes, they always resolve usually, but when the patient is having that much of hyperstimulated ovary, always manage the patient like OHSS, keep a watch on fluid and electrolyte balance, liver function, and the thromboprophylaxis. So this is again, and the hyperstimulated ovary is also prone to torsion. And when it is torsion, then again you have to deal it with the surgical detwisting by laparoscopy. Of course, it is always preferred, but when it is in emergency, it is not expertise, but it is the treatment which has to be done. All type of adnexal mass you can see into the pregnancy. Now, ectopic adnexal mass, always there. We have to be very, very ectopic minded, always. Low hemoglobin, UPT positive, and with the growing of time, when we see back 20 years ago, we are diagnosing late ectopic, suddenly patient in shock, but now we are more ectopic minded, and ectopic is still a black cat in a dark night. We have to be always very, very careful. Peri and the postmenopausal, where the risk of malignancy is like haunting our head. So this is the situation around 40-year-old, thin septate. This is a follicular cyst, and what you are going to do. It is a real confusing thing for profession as well as the professional body. And again, I will say you have to see the patient in full. What is her reproductive history? What were the protecting factor? What were the aggravating factor for ovarian malignancy? And what you want to do. So risk factor, protective factor, what is the age of the patient? That sets the stage. What is the chance of malignancy for this particular adnexal mass? So always see the patient as a whole. This is one important. Don't see only ultrasound, don't see only the picture, but we have to see as a whole. So adnexal masses are very, very common, and there has been a lot of guidelines simple guidelines which have come, which can like help us to differentiate what is the malignant potential and what is the benign potential. And this is usually thing ultrasound morphology. If it is benign, then only follow up, and in some situation, then you can do surgery. And when there is a in between, you are really everything is in between, then you go for the MRI. MRI is not that much needed. I strongly say that nowadays people are switching to MRI at like a blink of eye, but with a good, and usually I have not found them useful, and I think most of the gynecologists will like agree to it. So IOTA analysis, IOTA group has developed a very, very good characterization. You see, it is such a simple that we all gynecologists can like do in that mindset that we are having B rule or M rule. If there is even a one M rule, then you should refer the person to the oncologist and with the full like modality treatment. Likewise, we have the risk of malignancy index, like it has got a 1 point premenopausal, postmenopausal, and what are the ultrasound findings. So when we do the ultrasound scanning for adnexal mass, we should be very, very scientific, both ovaries, how much is solid area, what is the septa, septa is thin, partial, or they are thick, or they are going across, what is vascularity. So that give you good idea which patient need immediate surgery and the full workup, and which patient need only follow-up. What about the tumor marker CA125? We are doing always, but I want to warn that it is raised in premenopausal women for many, many reasons, and only when if it is more than 200, 250, then it is important. The lower values are not that mimic, they do not mimic for the malignancy. But in postmenopausal women, even more than 35 U per ml has got the important, and there are a lot of gynec and the non-gynec condition which can cause the CA125 rise, and the like don't make yourself panicky and the patient panicky for this. Again, a different germ cell tumor have got the different tumor marker, and we should be careful that when we have suspect that we do for AFP, beta HCG and LDH. HE4 protein is a part of Roma, that is a risk of malignancy oligograth, but usually nowadays still professional guidelines is not addressing, not recommending it for the diagnosis, but it is being used for monitoring recurrence or progress of the epithelial ovarian cancer, and it is not raised like CA125 for variety of benign and malignant condition, and that is the some add-on with the HE4. So 5 centimeter is a like a landmark sort of thing, that if it is more than 5 centimeter, we should be very careful and follow up. And this is important slide, which I want to say, low risk, repeat ultrasound at 3 months. Don't go just after 10 days or 15 days, 3 months, 6 months. If it is intermediate risk, previous 6 weeks followed by 3 months, 6 months, and then yearly. Premenopausal women, routine CA125 is not required, but if initial levels are high, then the surgical exploration should be considered. So this is very, very important. Now, again, it is a controversy. I think I have done like quite a clear job that which type of adnexal mass require only follow-up and which require the further workup and the surgical exploration. So life is full circle. Post-menopausal women nowadays, with the got a menopausal society president is with us, Dr. Sharda Jain, who has been active so much in Dr. Hara Patnaik, and we know we have now a huge people who are living beyond 60, 70, and they come with their own suffering. Sometimes I really say that they have this at this part of life, they have this thing, malignancy, and we are really taken aback when a 70-year woman or the 65-year woman come with this ovarian mass with vascularity, and the CA125 is increased, and this is the issue that ovarian cancer, still it is less than in our setup. We are fortunate in many ways. So Western, as compared to Western world, we have a less incidence and a more indolent type of ovarian cancer, but still due to population, we have quite a lot of junk. And all very, very large group studies, it is around millions of women, UPSTF as well as UKCTF. They don't recommend the routine ovarian screening in general population because it does not add to the prevention of morbidity and mortality, and it led to more surgical intervention for diagnosis of ovarian cancer. And those surgical intervention has got their own problem because it is elderly age group. So no routine recommendation, but when we see any adnexal mass in postmenopausal women, be careful, do iota RMI index, do all tumor marker and plan accordingly. And whenever you are in doubt, then MRI visit with us. So in postmenopausal women, the follow-up is a little different. Repeat ultrasound and CA-125 at 3 months and 6 months in low risk. Repeat TVS and CA-125 6 weeks followed by 6 weeks, then every 3 to 6 months, and then yearly. So we need a very careful follow-up. A little bit about the Lynch syndrome and the heritable cancer syndrome, because all over the world we say no ovarian screening, cancer ovarian screening for general population because it is not beneficial and it may be harmful. But the women and families who are having ovarian, breast, colon cancer and has BRCA gene and BRCA1/2 mutation, they are different, and we have to identify those. It is not necessary that we do every BRCA1, BRCA2 for our population, but take history that in your family, male member have colon cancer, any breast cancer incidence, any ovarian cancer incidence, and then you follow them. If they are carrier, they should have the annual rectosigmoid vaginal examination, CA-125 and TVS till age of 35. And after completion of childbearing, prophylactic bilateral salpingophorectomy. So this is important that the BRCA1, BRCA2, family history of Lynch syndrome, family history of cancer syndrome, they require a totally different approach. And I want to emphasize this, that please take history of cancer in the family. And when you find anything, these patients, even though they don't have the adnexal mass or something, they have to be followed up. When to refer to oncology unit, today every field has got their scientific advancement, and like 20 years or 15 years ago, we used to do a lot of surgery, and now we want to refer to the specialized unit because every science have developed and a clear message when to refer to oncologist when the premenopausal woman CA-125 more than 200, ascites, evidence of metastasis, and family history of breast and ovarian cancer in first degree relative. So this history is very important. Postmenopausal women CA-125 even more than 35, ascites, nodular or fixed pelvic mass, evidence of distant metastasis by CAT scanning or the imaging, and again family history of breast and ovarian cancer in first degree relative. So and the ovary, what is possess a mysterious physiology that affect all organs from head to toe. It is for the vigilant clinician to decide they want me as a friend or foe. Thank you very much. Life is full circle. From we take birth, grow and decay and die. Be always vigilant, knowledge and a compassionate doctor for our patient. Don't frighten them with the technology. Don't frighten them with the medicine, but always be a compassionate. And we remember Mahatma Gandhi on this pious day. We are with you. So we are very fortunate to remember him. And I seek your full-hearted support for my candidature for FOXI president. Thank you very much.
Thank you, ma'am, for the excellent talk. It was so excellent to say. So you have covered all the aspects, multidisciplinary approach, which investigation has to be done. Thank you so much, ma'am. And thank you also for reminding us on the 74th Matron Day of the Father of the Nation, Mahatma Gandhi. And we wish you, on behalf of Vijayawada Obstetric Gynec Society, we wish you all the best for the election of President for FOXI. Thank you so much, ma'am. Over to you,
I invite Dr. Indira to please take over for second session and introduce the speakers. Indira, ma'am.
Hello.
Yeah, madam, we can hear you.
Audible? Okay.
Can we have the CV of Dr. Queen Aditya, please?
Oh, Dr. Queen Aditya, good morning. Good morning to all my junior and senior colleagues. I'm Dr. Indira, HOD, OBG department, KMC Kurnool. I'm happy with you today because Sunday is the very best day for us to relax, but at the same time, relaxation with the Foxy members and the senior and junior colleagues is very, very happy. And she's Dr. Queen Aditya is a consultant gynecologist at Army Hospital, KMC Calcutta, and she received APJ Abdul Kalam Award of the Appreciation from DGF in 2015. She received GM from CM of the West Bengal as a best girl candidate as HS exams in 1988. And currently she is working as a East Zone coordinator for Sexual Medicine Committee of 2021. She is a regular faculty of National Conference and speaker in various TV health shows. Dr. Queen Aditya, welcome to this session, madam.
Thank you so much, ma'am. Thanks for your very, very kind words of introduction. And without wasting time, should I share my screen?
Yeah,
Okay.
ma'am.
Yeah, thank you. What has happened? Yeah. Just 1 second. Just 1 second, I'll have to.
Just make it slide.
Yeah. Mine is showing slide share, right?
No, madam.
It's not, I'll have to do it again. I'll do it again then. Okay, I'll do it again. Because when I was trying earlier also, again, I'll try. Is it coming as slide share? Full screen? Okay.
Yes, ma'am.
It's coming full screen. Okay.
Yeah.
Okay. Thank you so much to the organizers, respected Sadhana ma'am, respected Sharda Jain ma'am, Ambuja ma'am, and respected chairpersons and seniors. Thank you so much for giving me this wonderful opportunity to be presenting in front of you all. As obstetricians and gynecologists, there is nothing new to speak about fibroids, but still, as a recap, it's a benign tumor of muscular and fibrous tissues typically developing in the wall of the uterus, and up to 40% of women over the age of 40 have them. And the classification, the recent FIGO classification, as we all understand, from 0 to 8. 0 is starting from the pedunculated intracavitary till 8, which is other, and 7 is subserosal pedunculated. That is the classification of the types. Risk factors is early onset of menarche, late reproductive years, obesity, family history, and certain races like blacks. Symptoms, as we all understand, can be menorrhagia, pelvic pain, dysmenorrhea, anemia, infertility, and the pressure symptoms. So, unfortunately, many women are having them, fortunately or unfortunately, but they sometimes are discovered incidentally on clinical examination or imaging in asymptomatic women. The prevalence, according to the government of India, is showing that it's above 35 years, it's around 21%, 36 to 40, 41%, 41 to 50, 56, it's 46 to 50 and 51 to 55. This age group is obviously has the maximum number of cases, and it will decline after 55 because of menopause. Diagnosis, usually the history is suggestive, but it can be asymptomatic in many cases, as I have mentioned. And the pelvic examination usually is suggestive in most of the cases. Ultrasound, ideally nowadays we go for a TVS, and it has 90 to 99% sensitivity, but some may miss submucosal or very small fibroids. Sonohysterography, hysteroscopy, these are nowadays also used to help to identify the submucosal fibroids. Rarely MRI or 3D ultrasounds may be required. The lab investigation, the usual, at least the CBC to rule out a pregnancy and a TSH are of prime importance. Ultrasound, as I mentioned, grade A is the USG mostly, that is the TVS. Doppler ultrasonography may be required to suspect, in cases of suspected arteriovenous malformations, malignancies, and to differentiate between a fibroid and an adenomyoma. SIS can be required in case a intracavitary lesion is suspected, and hysteroscopy where it is not available. And hysteroscopy is nowadays also grade 1 to diagnose the submucous variety. 3D ultrasound, which I already mentioned, helps us to evaluate intramyometrial lesion in selected patients, and especially for fibroid mapping, wherever that becomes relevant. And MRI may be used to differentiate between fibroids and adenomyomas, and for mapping exact location of fibroids while planning conservative surgery and prior to therapeutic embolization of the fibroids. This is also grade A evidence. Sonohysterogram, hysteroscopy, and MRI are clearly the best techniques available to diagnose the presence of an intracavitary or submucous fibroid. There are certain studies out here, and MRI out here proved to perform the best with 100% sensitivity and 91% specificity in this particular study by Fukuda. The management options. As we all understand, surgery is the first choice of treatment. But it was when we were students, as Sharda ma'am has mentioned, that when they were students, it was a totally different ball game. So even we as students learned that surgery is the first choice of treatment. But in the current years, the medical therapies have been used before surgery to improve intraoperative and postoperative outcomes, and in some cases also to buy time before the surgery and to build up the hemoglobin. So though I cannot speak about the medical management as a definitive mode of treatment, but it is definitely there, and it has definitely made its place in today's management options. So the various management options are the medical, the surgical, and some of the alternatives like the uterine artery embolization or the ablations. So coming to asymptomatic fibroids. As far as asymptomatic fibroids are concerned, expectant management is recommended for asymptomatic patients because most fibroids decrease in size during or after menopause. Management should be tailored to the size, but I cannot speak about asymptomatic fibroids in all cases. It has to be tailor-made. So the management should be tailored to the size and location of the fibroids, the patient's age, symptoms, desire to maintain fertility, and access to treatment, and the experience of the physician will also matter. And our patients, whenever we tell them that there is a fibroid, it's a tumor inside your uterus, no matter how much we tell them it's benign, they get scared. So we have to point it out to them that the possibility of malignancy is very, very rare. So this is something that we should tell them to reassure. Indications of definitive surgery will be persistent abnormal uterine bleeding, excessive pelvic pain that is incapacitating the patient, pressure symptoms, anterior and posterior, rapidly enlarging fibroids, which might point towards it becoming malignant, and fibroid-related infertility issues, and also in certain cases of recurrent pregnancy loss. So the various surgical modes of treatment are there, but the drawbacks I'm just going to talk about. When we talk coming to hysterectomy, there is surgical morbidity, there is a risk of surgical long-term complications, and obviously total loss of fertility. So I have come across, I'm sure all of us have come across a woman coming to us who have been to a previous doctor, and in the late 30s or even in the late 30s, suppose they've undergone a hysterectomy, and now they were thinking of a pregnancy, but because the uterus has been removed, now they cannot think of their natural conception. So there have been cases like this. Myomectomy, we all understand that it is notorious for recurrence of fibroids, and the potential uterine rupture during pregnancy or delivery, that is also something that we have to think about, though the frequency is not that high. Coming to the other modes, when we're talking about uterine artery embolization, the disadvantages are the fibroid recurrence, pain, possible post-embolization syndrome, possibility of severe complications, subsequent hysterectomy, and it can give rise to potential ovarian failure and abnormal placental development as well. So coming to medical therapy, which we are now talking about, several years back, we did not even think of this as an option. But now coming to the medical therapy, the ideal medical therapy for fibroids will be a tablet, because patients will want a tablet more than something that is invasive or like an injectable or something like that. So a tablet that is taken by mouth once a day, or even better once a week, with minimal, if any, side effects, that induces fibroid regression completely, and thus resolutions of symptoms very quickly, but without affecting fertility, and at the same time has very prolonged and long-lasting effects. But unfortunately, such a product we do not have in our armamentarium yet. So coming to the scope of medical treatment, although definitive treatment of fibroids relies on surgical therapies, medical treatments are considered the first line treatment to preserve fertility and to avoid or delay surgery. And specifically in perimenopausal women who are waiting for the menopause to happen and thereby for the fibroid to regress, and in unmarried women who are really wary of any kind of surgery, most of the women are not open to surgical techniques before they are married, or even in married nulliparous women. Very few are open to surgeries. So coming to the options of the medical management, we all know about the levonorgestrel intrauterine system. A few words about it. It causes a reduction in the uterine volume and bleeding with increasing the hematocrit, and it is also approved by FDA for this particular indication. The added advantage is that it gives us contraception, and we all know that it came to us primarily as a contraceptive, and later on its role in managing menorrhagia came later. But the problem might be difficult insertion in cases of distorted cavity, and in such situations, even if we manage to introduce it, the expulsion rate might be very high. So it is not amongst the front runners of the medical management. Coming to GnRH analogs, it was first used by Filicori in 1983. These drugs initially increased the gonadotrophin release, followed by desensitization and downregulation, causing hypogonadotrophic hypogonadal state resembling menopause, and gives rise to amenorrhea and 50% reduction in uterine size within 3 months in most of the cases. But there is rapid resumption of menses after discontinuation, so the effects remain short-lived. Driven by the observation that fibroid growth is hormone dependent, current medical treatments mainly involve hormonal manipulations. GnRH analogs have been most widely used, and while they do cause fibroid regression, they can only be used in the short term as temporizing measures in the perimenopausal women. They are notorious for rebound growth of the fibroids once cessation of therapy happens. The use of GnRH analogs for 3 to 4 months prior to fibroid surgery reduce both uterine volume and fibroid size. They are beneficial in the current correction of preoperative iron deficiency anemia if present, and reduce intraoperative blood loss. And these are the findings found by Lethavi and Wallenhoven in their series in 2017. But the drawbacks of GnRH analogs, which we all understand, is severe hypoestrogenic state, which can give rise to severe osteopenia and even osteoporosis. And it has been found if 6% of bone is lost after 12 months, only 3% is regained, that the total amount of bone lost is not regained. So that is also very, very big drawback. Now coming to GnRH antagonists, they avoid the initial flare-up effect that happens with the GnRH analogs, but otherwise do not appear to have any additional advantages over GnRH analogs, and have not been used in a widespread way, and more studies are required before we actually advocate them. Raloxifene is an SERM, which we all understand, selective estrogen receptor modulator. It induces fibroid regression effectively in postmenopausal but not premenopausal women. And experience with these drugs is limited, and they are associated with significant side effects. Hence, they are also not amongst the front runners of the medical management of fibroids. Danazol, as we all understand, is effective, but the severe androgenic side effects prevents us from actually prescribing the same. Aromatase inhibitors have also been tried. They've been utilized with some promising initial results in shrinkage of fibroids without some of the side effects of the previous drugs. A pilot study showed that the use of anastrozole, 1 milligram daily for 3 months, decreased fibroid tumor size by 55%. However, more RCTs and more studies are required before we can actually advocate usage of the same. So limitations of the pre-existing medical therapy, progestins earlier were used, COCs, all of them have their side effects as we understand. GnRH analogs, I've already mentioned the severe hypoestrogenic effects. Ulipristal acetate, which was in use a few years back, because of the several reported cases of liver failure and also endometrial hyperplasia in some cases, it has fallen out of repute, though probably it is being reintroduced once again. So estrogen and progesterone play an important role as far as fibroids are concerned, and fibroids overexpress estrogen and progesterone receptors. Progesterone plays vital role in promoting uterine fibroid growth, and progesterone receptor binding is 3 times higher in fibroid as in the normal myometrium. This is a very important factor, and the progesterone effects on fibroids is that progesterone is believed to be physiological regulators of uterine fibroid growth. It increases the B cell lymphoma 2 protein expression, thereby inhibits apoptosis. It increases epidermal growth factor, thereby increases angiogenesis, and also reduces the tumor necrosis factor alpha, thereby increases fibroid cell proliferation. Coming to mifepristone, which is the first selective progesterone receptor modulator. It has anti-progesterone effect, and there are more than 35 clinical trials, and including many Indian trials about this particular medication. It has been used both in the 10 and 25 milligram dosage. Mechanism of action is that it has an antagonistic property. It binds strongly to the endometrial progesterone receptors, minimally to estrogen receptors, and upregulates the androgen receptors. It reduces the myoma size, might be due to the direct effect in reducing number of progesterone receptors. Because of the ovarian acyclicity seen with mifepristone, the hormonal milieu similar to early follicular phase may also inhibit the steroid-dependent growth of the myoma. Increase in androgen receptors also contributes to the anti-proliferative effects, and mifepristone also delays or inhibits ovulation, which may produce amenorrhea as well. And it also has direct suppressive effects on endometrial vasculature as well as on reducing stromal vascular endothelial growth factors, and has also been suggested for reducing menstrual blood loss by all of these mechanisms. And when we are comparing with GnRH analog, that has only the effect on the pituitary, and this mifepristone will have effects also on the pituitary as well as directly on the endometrium and also directly on the fibroids. So all of these mechanisms combined, it is giving us good efficacy as far as management of the symptoms is concerned. So advantages over the other therapies is that it is almost as effective as GnRH analog, probably more in certain studies we have found. It has no effect on bone mineral density, no risk of osteoporosis unlike GnRH analogs, has lesser side effects, oral route of administration with good compliance, allows time to correct anemia and plan surgery. Menses usually revert after 34 days, 5 to 85 days, and therefore if someone is contemplating a pregnancy, we have to explain to them that while you're taking the medication, it will not happen. Probably 2 to 3 months after stopping the medication, you can plan for a pregnancy. So that is something that it is still there in our basket. Lesser recurrence of fibroids after cessation of treatment as compared to GnRH analogs, and it improves the health-related quality of life. So this study by a Chinese study shows that a comparison of the surgical time, blood loss, and intraoperative blood transfusion rate revealed that that all of these indices were significantly better improved in the research group, that is in the mifepristone group, compared to the control. And moreover, the post-operative pain scores of the research group were significantly lower than that of the control group. So this Chinese study has shown us promise as far as preoperative usage of mifepristone is concerned. Cochrane data has shown us that they might give us effective treatment for women with symptomatic fibroids, and the endometrial changes, if any, are benign and not precancerous. And this is also, Cochrane review is also telling us that mifepristone reduce heavy menstrual bleeding and improve the fibroid specific quality of life. This study has shown us that mifepristone showed reduction in leiomyoma size and improvement in the symptoms. Another study out here has concluded that daily treatment with mifepristone for 3 to 6 months as optimal clinical treatment for leiomyoma, insufficient evidence of atypical endometrial hyperplasia with mifepristone, which usually is not found. So, so many of these studies are comparing the various modes. In most of them, GnRH analogs are also found to be effective, so also mifepristone. So both of them have been found to be effective as far as the management of the symptoms are concerned. Some of the guidelines I'll just like to speak about. Society of OBGYNs in Canada, that is the SOGC. It spoke about effective medical treatments for women with abnormal uterine bleeding associated with uterine fibroids, which includes selective progesterone receptor modulators. And in women who present with acute uterine bleeding associated with uterine fibroids, conservative management with selective progesterone receptor modulators is accepted mode of treatment. So this is our own Indian study by our very favorite Dr. Alka Kriplani ma'am. And I remember when she was doing this study, then it was not even approved in India. And obviously it was in the study phase. And she had to break the tablets into very small parts, and that is how it was used. So according to that study also, newer medical options like low-dose mifepristone, which was at that time not available, they found it quite effective. So the same study is showing us that conclusion from that study was that mifepristone 10 milligram or 25 milligram both cause symptomatic relief with a lot of reduction in menstrual blood. Greater myoma size reduction occurred in the 25 milligram compared to the 10, and amenorrhea developed in around 90 to 95% patients, and it can be a reasonable choice for management of uterine leiomyomas as it is administered orally, cost effective, and has very mild side effects. So it can be a good choice for us when we are especially in perimenopausal women in whom myomas, we are expecting them to regress after menopause. So to buy that time up till menopause, it is a good option. Another Indian study, here what they did is that they used mifepristone for 3 months and gave one month gap, again 3 months, total they used for 12 months, and followed the patient up, and they found that the change in fibroid size was found shrinkage in around 98% of cases. Hemoglobin was also increased, and with the increased treatment duration, that is total of 12 months of treatment with three months and 1 month gap. In this way, total 12 months, more patients responded better with increased duration of this management. So some more are controlled trials with comparing with GnRH analogs show that mifepristone is as effective as the GnRH analogs. It is better tolerated, less recurrence rate with mifepristone compared to GnRH agonists, and is more effective in decreasing the blood flow to the uterus than the GnRH agonist. Another study is showing marked relief with significant decrease in visual analog scale score in both groups when GnRH analog and SPRM is compared, and treatment with mifepristone 25 milligrams for 3 months significantly reduced bleeding, uterine volume, and myoma volume. So most of the studies are showing that it can be a good choice, especially in perimenopausal women. I think most of the studies are telling us it is a good choice in perimenopausal women where we want to defer surgery. We do not want to go in for a surgery. We are waiting for the menopause to happen. And in some of the studies, they're telling us that when we are waiting for a surgery, then it is a good option to buy time to increase the hemoglobin, and also the intraoperative and postoperative outcomes are more favorable. So also, we see that in all of these, there are better effects and no major side effects observed during the course of these studies. Another Indian study showed that decreased uterine and fibroid volumes were measured by TVS as far as usage of mifepristone was concerned. In most of these, the uterine volume, in the study also, the uterine volume was reduced, and also the fibroid volume to a great extent. Most of these studies also who used mifepristone have shown us promising results, that there is improved quality of life. Some are saying that the uterine volume and the leiomyoma size, they all reduced. Here also, Shikha Sheth is showing mean uterine volume reduced by around more than 60%, and complete resolution of complaints such as menorrhagia, polymenorrhagia, etc. So as far as preoperative mifepristone is concerned, it is showing us improvement in surgical time, blood loss, less blood loss, reduction in surgical time, less blood loss, intraoperative blood transfusion rate goes down, post-operative hemoglobin levels improve, and the mean hospital stay is also less. Cochrane 2012 has told us that mifepristone reduced heavy menstrual bleeding and improved fibroid-specific quality of life, but they said that it was not found to reduce fibroid volume in that particular series. Further, well-designed, adequately powered RCTs are needed. That is what they had told us in 2012, but we have come across so many studies after that. And it is now being approved by AICOG, ASRM 2009 and 13. As far as the safety is concerned, even up till 50 milligrams per day, it is found to be safe. There is no atypical hyperplasia in any study that has been published. No pre-malignant changes, and no risk of decrease in BMD or osteoporosis, and little or no elevation in the liver enzyme. So all the side effects that we are getting with the other medications, mostly in mifepristone, we are hardly coming across any of those side effects. So the dosage is once daily, that is 10 milligram or 25 milligram. 25 milligram was more effective as found in most of the studies. It should be started in the first 7 days of the menstrual cycle and should be taken same time every day, as we understand, and minimum treatment duration should be 3 to 6 months. So coming to our conclusion, we know now that various modes of medical management of fibroids are available, but none have permanent effect. Mostly are used to buy time and build up hemoglobin before surgery. Medical management is of pivotal importance in the perimenopausal woman and also in the unmarried woman. Preoperative medical treatment improves the intraoperative and postoperative outcome. And coming to the other modes of treatment, the levonorgestrel IOCD is effective but difficult insertion in distorted cavity. GnRH analogs are effective, but severe hypoestrogenic effects really make us think twice or thrice before actually prescribing them. Danazol, as we all understand, has severe androgenic side effects, hence we hardly use. So coming to the SPRM, currently we are using mifepristone. Ulipristol will probably might come back to the market, but was temporarily, it was suspended for some time. And these SPRMs seem more effective than the other options with fewer adverse effects and giving us good effects as far as the symptomatology, the visual analog scale, the PBAC, all of these are giving us all of the parameters are giving us better results as far as when we compare mifepristone with all the other modes of treatment. And if we are using them preoperatively, then intraoperative and postoperative outcome is usually found to be much better. Hence, it is one of the good drugs in our armamentarium, though GnRH analogs, in spite of having the severe hypoestrogenic effects, is also used widely. And I thank you all for your patient listening.
Thank you, Dr. Aditya, for giving a good knowledge about the medical treatment of fibroid uterus. I got one question.
Yes, ma'am.
Postmenopausal woman, asymptomatic, and with a small fibroid of 2 to 3 centimeter by ultrasound, how long we have to follow the patient? Can you suggest, are there any best medical treatment other than surgical treatment?
Ma'am, as I have already spoken, I think raloxifene has been used in postmenopausal women with some benefits. Other medication usually in postmenopausal women are not used. There are very few studies about raloxifene, but that is one of the medications that is used in the postmenopausal period. But as all of us as clinicians, I think we are very scared to hold on to fibroids in the postmenopausal period, and we will go for very frequent follow-ups. And because the patient is also very worried and we are also worried, in most of the cases we land up in surgery. But if any kind of medical treatment is thought of, I think raloxifene has been studied, if not extensively, but to some extent in the postmenopausal age group. Other medications mostly we do not prescribe in the postmenopausal age.
Now, how long we have to follow the patient? How long we have to follow the patient?
Ma'am, I probably, as Sadhana ma'am had said, that in the perimenopausal, postmenopausal, probably every 6 weeks we go for a follow-up. And if the ultrasound is suggesting that it is persisting, then probably more than 3 to 6 months, we will not wait.
Okay. Thank you very much for your work.
Thank you, ma'am.
Shailaja?
Yeah, madam. Please introduce Dr. Asha Rao. We'll go on to the next topic.
Good morning, madam. Welcome to the session. I will introduce some few words about Dr. Asha Rao. She's the chairperson of Endometriosis Committee of FOXI 2022. And she is an experiencer of 25 years in ERT. She's the director of Rao Hospital and Care Hospital, Coimbatore. She's the director of fellowship program in reproductive medicine and endocrinology, and affiliated to Tamil Nadu, Dr. MGR Medical University, Chennai. She is the past president and Coimbatore OBG Society of 1719 and 93-94. She is the organizing person of Endo Insight 2021 International Endometriosis and Congress FOXI and she is the organizing chairperson of UVA FOXI South Zone in 2019, and she is the chairperson of IAGG Star Endo-Gynecology Conclave in 2019. She is the chairperson for 8th National ASR Conference in 2001. She is the gold medalist from President of India from University in the final MBBS. And she delivered the first IC baby of committee in 1998, and first Victor Fadidesh is the baby of Coimbatore 2008. And she trained at London and Britain's underworld renowned experts.
Thank you, Dr. Indira, for those kind words. And at the outset, let me thank Dr. Sadhana Gupta and the WOX team for having invited me here today to share my experience on my favorite topic of endometriosis, the medical management. Let me just start sharing my screen. Endometriosis, the disease which is known for more than 150 years, continues to be ever elusive and enigmatic. Almost every woman has retrograde menstruation, but we do not know why some women suffer from the disease and some others do not. And we have more than 190 million women suffering from endometriosis globally. Of these, 30 million women belong to India alone. And younger the disease, more severe is the condition. About 40 to 60% of women suffer from dysmenorrhea, 75% with chronic pelvic pain, and about 30 to 35% with infertility. And these are the various sites, as all of you know. And the 7 Ds, the symptoms of endometriosis: dysmenorrhea, dyspareunia, dysplasia, DUB, difficulty in conception, and finally, an atrocious delay in diagnosis, which is almost 6 to 8 years. This is why we have been conducting programs over and again, because we have to spread awareness, not only among patients, but also among clinicians about diagnosing it early and treat it right. And a disease of multiple etiologies, retrograde menstruation, hormones, immune dysfunction, apoptosis, genetic theory, stem cells, etc. And we can see this retrograde menstruation, which starts as a tiny thing, makes a home in the peritoneum, on the ovaries, and each of these tiny deposits become the hormone factory producing angiogenesis, neurogenesis, steroidogenesis, proliferation, invasion, and survival. So they have their own government and they know how to survive and how to make our women suffer. They bring down the quality of women's life, and it's an estrogen-dependent disease and increases the aromatase activity, decreases the apoptosis, and there is progesterone resistance in these women. And how do we manage this agonizing condition? Year after year, I have seen women suffering by endometriosis, and also that is the problem, but also by the injury and insult of multiple surgeries. So this is where we clinicians today have to gather and say, let us try to reduce the number of surgeries. What does surgery do? It removes adhesions and adhesiolysis. And medical management is done to destroy or lyse the lesions and prevent the recurrence of lesions. And according to the American Society of Reproductive Medicine, endometriosis is a chronic lifelong disease. And one has to see that we avoid the number of multiple surgeries and promote medical management. to alleviate pain and promote fertility, reduce recurrence, and improve the quality of life in these suffering women. And the factors deciding the choice of treatment depend on age, the desire for fertility, symptoms, severity, cost, side effects. All these have to be considered. And this is a favorite chart. If it is infertility, we go in a different direction, maybe depending on the condition, expectant management, laparoscopic surgery, IVF, etc. But when it comes to pain, one can very definitely help them with medical management. When the pain is mild to moderate, consider empiric treatment with OCP or progestins, and there is no need to do a diagnostic laparoscopy as we did earlier. No wonder it's the gold standard for diagnosis, but today, according to ESHRE, we can treat women with empiric diagnosis and start a therapeutic trial of OCP or progestins. And if the pain is moderate to severe or not getting controlled with medication, one can go in for a laparoscopic confirmation with surgical excision, but definitely follow it up with medical management immediately to avoid recurrence. This is what many clinicians are forgetting, because the women get lost for follow-up. They do not take medication. They come back to you again after 1 or 2 years with huge recurrence. So this is very, very important. So what does the medical management do? Suppresses the estrogen, reduces retrograde spill, overcomes the progesterone resistance, anti-inflammatory action, aromatase inhibition, anti-angiogenic, and immunomodulation. We should know all these things because this is the only way we can combat the disease. And we do not have an ideal medication yet, which treats women well and prevents recurrence. The currently, Danazol was a real friend in the yesteryears. I remember in 1993, I treated a woman who had severe dysmenorrhea, married 16 years, yet she was 34 years. And she had bilateral tubal block, and all that we offered her those days was Danazol. Empirically, we gave her Danazol after a diagnostic laparoscopy. And when she stopped Danazol at the end of 6 months, the lady who was set to her tubal block, she conceived. And the girl who was born in 1993 got married last year, and it was such a happy occasion. But this wonderful medication lost its popularity because of the severe androgenic side effects. So now our popular medications are oral pills, NSAID only for pain, Dynogest, aromatase inhibitors, GnRH agonist, and GnRH antagonist. And each one of has their own side effects. NSAID have the nausea, vomiting. OCP progestins can give you weight gain, fluid retention, depression, amenorrhea. GnRH agonist can cause profound hypoestrogenism, loss of bone mineral density, and Dynogest has a slightly better safety margin, much better safety margin compared to many of these medications. So how do we treat stepwise? The first line of therapy today, according to ESHRE guidelines draft 2021, is combined oral contraceptives or progestins. And surgery is the second line. And GnRH analogs also come as the second line. And then we have the need for long-term medication. COC have been time tested for over years. I'm sure I have used it for more than 25 years. But today, progestins are slowly turning to be the wonder drug, because COC, we are still not sure. There have not been that many trials exactly regarding the reduction in the size of the lesion, long-term side effects on the endometriosis. And there are now papers by Casper et al. Who say that the estrogen component of the COC perhaps can sometimes promote progression of the disease. And these girls who have pain relief could perhaps land up even with deep infiltrative endometriosis. So this sort of anxiety is there. And progestins seem to be the right type of medication. They have the effect of desudalization. They cause the atrophy of the endometrial tissue, anti-angiogenic effect, anti-inflammatory, immunomodulatory effect. All this cause a good pain relief and regression of the lesion. And according to the ESHRE guidelines and also the guidelines from World Endometriosis Society, the newer progestins such as Dynogest can be considered for use as first-line medication empirically without doing a diagnostic laparoscopy, because in young girls, this is perhaps why the diagnosis gets delayed, because we do not want to do a laparoscopy. And we just keep telling them, no, beta, you have to manage with this. Don't see a doctor. Don't take medications. So this sort of thinking has to stop. When young girls come to you with pain, if you suspect endometriosis, you can definitely start them either on OCP because they're more affordable. I would rather prefer Dynogest because the safety margin is much better. So do a therapeutic trial rather than a laparoscopy. And you can see that Dynogest is a wonder drug of the decade. It has progesterogenic activity and anti-androgenic activity, but does not have glucocorticoid activity and no mineralocorticoid activity. And it has both central and peripheral action, causes inhibition of gonadotropin secretion, reduces ovarian function, anovulation, and it has anti-inflammatory, anti-proliferative actions. But the beautiful aspect of Dynogest is that it does not cause hypoestrogenism. It maintains the estrogen level between 30 to 60. So it does not promote endometrial growth. At the same time, it does not interfere with bone growth. So the bone mass is maintained very well. If you use it for more than 1 year, perhaps there could be 1% drop in the BMD, which is hardly significant. And it has very good properties on the utopic and ectopic endometrium, reduces the aromatase activity in the lesion, causes apoptosis, decreases bleeding and pain. And it can reduce the dysmenorrhea, premenstrual pain, dyspareunia, and diffuse pelvic pain. The dosage normally is about 2 milligrams per day. And it significantly reduces the size of the endometriosis lesions. When used for 24 weeks, you do not expect a regression within 2 weeks or 2 months. At the end of 24 weeks, more than 80% of patients, there was reduction in the size of the lesion to the extent of 75 to 80%. And this is one of the latest papers, which again supports that the reduction in the size of the endometrioma is almost 75% by the end of 1 year. And you can compare it to GnRH analog. GnRH analogs were always my favorites. But today I've come to believe that when used Dynogest for 24 weeks and GnRH for 24 weeks, the pain reduction is almost equal, minus the side effects of the profound hypoestrogenism of GnRH analog. GnRH analog, again, I admit that it's a wonder drug. That's my favorite in endometriosis, especially with associated adenomyosis. But for a long-term usage, definitely Dynogest scores over GnRH analog because of the tolerability and minimal side effects. And both have equal amount of pain reduction, GnRH analog and Dynogest. And for adenomyosis associated with endometriosis, it can give reduction of dysmenorrhea, dyspareunia, and chronic pelvic pain. Though the bleeding episodes could be there in Dynogest, and that is one of the nuisance problems of Dynogest. So somebody is severely anemic, you better not start them on Dynogest. You can give them GnRH analogs initially, and after 3 months, you can switch them over to Dynogest. And talking about recurrence of endometriosis, after surgery, within 1 year, 15 to 20% of women can have recurrence, and almost 40 to 50% recurrence in 5 years. And DIE also seems to continue. This sort of recurrence can be avoided beautifully with the help of long-term medication. GnRH you cannot use more than 6 months. OCP had a recurrence rate of 22% in 1 year, whereas with Dynogest, the recurrence rate was barely 2% at the end of 5 years, which is very impressive. Dynogest and the risk of endometriosis recurrence following surgery. This is one more beautiful paper by Minimally Invasive Journal in 2020, which supports that recurrence can be prevented to a great extent with Dynogest. This VISADO study is a study in 21 centers in 6 European countries in the pediatric age group of 12 to 18 years. And they concluded that Dynogest can be used for a period of 5 years and beyond, immediate return of fertility, cost effective in comparison to GnRH analogs. It can be safely offered to adolescents, and there is hardly any reduction of bone mineral density with good relief of pain and good suppression of size of the lesion, which is very, very important. And that's what we are looking for. The side effects of Dynogest are seen hardly in about less than 10% of patients: mild headache, depression, irritability, constipation, acne. Bone health, only 1% drop at the end of 1 year, which seems to stabilize later. Breast health is not affected. Bleeding irregularities occasionally are there, which is a nuisance problem. This is a WIPO study. WIPO study is the Visan post-observation study done in more than 25,000 participants, more than 80,000 woman years for 7 years in the European countries, which concluded the safety aspects of Dinoges, which is a very impressive study. Dydrogesterone, erythroprogesterone is being tried. LNG-IUS is a dear friend in the gynae clinics. A continuous exposure leads to atrophy of the endometrium. 60% can have amenorrhea in 6 months. Post-operatively, treatment with LNG-IUS reduces the recurrence and improves the pain. And many of my patients have continued. When I tell them 5 years, they come back at the end of 7 years and say, ma'am, I couldn't come. Shall I keep it for some more time? And now I saw that there were about 5 patients. One had it for 14 years, one had it for 10 years, and about 5 of them had it for more than 7 years. They did not come back at the end of 7 years because they did not want to remove the Mirena. They are so happy. We had to coax them to remove the Mirena and insert a second one. So LNG-IUS seems to be extremely effective, and it's also cost effective, and is a dear friend to women with menorrhagia and dysmenorrhea. Injectable progesterones have been used, but the nuisance is that of breakthrough bleeding. Dinosol, which was my dear friend, is trying to re-emerge in the European countries. You can use it as a vaginal ring. You can use it as a vaginal tablet. The oral vaginal tablet also was being used vaginally. Intrauterine device with 400 milligram of Dinosol was inserted for 6 months. This is a study by the Tosti and Petraglia group. Reduces dysmenorrhea, dyspareunia, and chronic pelvic pain. And they said the serum levels were very, very negligible. In fact, some patients had ovulation and pregnancies had happened. So if the patient does not want pregnancy, you should tell her not to, because I would rather be worried about the androgenic side effects, though they say the androgen levels are minimal. But this kind of, and even for the deep infiltrative endometriosis, it may be worthwhile considering vaginal Dinosol or intrauterine device of Dinosol. Aromatase inhibitors, our friends in infertility are also your friends in endometriosis. It lowers it reduces the pain, reduces the size of the lesion, which is very important, but they can also cause lowering of the bone mineral density. You can also use anastrozole 1 milligram. And even for adenomyosis, it seems to be giving very good reduction in size, almost to the extent of 60%. You can use letrozole along with norethistron. You can use also along with GnRH analogs. You can use it along with OCP. They reduce the pain and they can reduce the lesion. And this is one of my patients where we use it for adenomyosis. She has a 12-week size, 330 ml size uterine adenomyosis. She came during the COVID year, 2019 November. We did a vitrification of embryos, and January 2020, we followed her up for 8 months with 2 doses of GnRH depot, and again a third dose of 3.7, along with norethistron and letrozole for 8 months suppression. And in October 2020, she had embryo transfer. She conceived a singleton pregnancy. You can still see the remnant of the size of the adenomyoma. She did very well, and she had a term LSCS. So aromatase inhibitors are definitely worthwhile considering for endometriosis and adenomyosis. Elagolix, newer antagonist, not available to us. FDA approved drug, very expensive, can also cause reduction in bone mineral density. I have no experience and it's not available. Newer drugs like tamoxifen, riloxapen, the selective progesterone receptor modulators are being tried. Esoprostol, ulipristal is banned, of course. Mifepristone is being tried. It can cause hypoadrenalism, one of the major side effects. It can reduce the size of the lesion. Statins are being tried. They have immunomodulatory effects. And angiogenic inhibition properties of cavagolin seem to be useful. So the dopamine agonist, 0.5 can be given twice a week for a short while for acute reduction of the pain. It has anti-angiogenic and neuroangiogenic properties. Effect can be effective in the treatment of DIE. To conclude, endometriosis is a chronic inflammatory disease which requires supportive and continuous medical therapy. Medical management should replace surgical management prior to ART or in any context in the woman's life. Chaperone is somebody who fights for women. So today, our method of management is whenever we diagnose endometriosis, we give them medication for a short while. If there is a small recurrence, we go in for surgery easily. But what he says is, give them a non-surgical management, medical management. Do not do surgery for a young girl when she comes to you at 17, 18. You can keep them on medical management for almost 7 years, according to the new research from Gynecology. And later, when she wants a pregnancy, you can either take her up for a unique surgery if necessary or if she has severe pain. Otherwise, you can go for ART. And once there is a childbirth, again follow it up with long-term medical management. So try to avoid surgery as much as possible. And at the end of this long-term medical management, if she has a severe recurrence or she is fed up of taking medical management, then you go in for a single appropriate definitive surgery when she completes her family. So try medical management and avoid surgery. This is my request to all of you. And once again, a paper regarding Gynecology. Is it the best medical treatment for ovarian endometriomas? This is once again coming from Italy. So lots of papers to support medical management. Thank you once again for a patient hearing. And thank you, Dr. Sadhna, for giving me this opportunity. And I wish you great luck in your forthcoming elections. Thank you.
Madam, thank you, madam. Thank you very much for giving a good medical management treatment for endometriosis. But I got a very small question. Suppose there is a severe endometriosis when you go for surgery. What is the post-operative complications? I think it is not only the fibrosis. Any more complication do you expect, madam, in this case? Like any surgery?
If somebody has severe endometriosis, how do you manage? Is that what you're asking me?
No. You are telling medical management always better. We will always prefer to have that.
No, but
suppose severe endometriosis where the patient cannot get
yes, definitely surgery has a very big role. Let us try to avoid surgery as much as possible. In case you suspect DIE, going in for compression of the ureter, bowel problems, hydronephrosis, you should not go on giving Gynecology. I saw one patient coming last year from a neighboring city. She had already hydronephrosis. In spite of this, the doctors put her on Gynecology for 1 year. And when she came to us, the kidney was almost like a bag. She only had a 15% functioning in the kidney. So it's very important to see, is she going in for complication? In which case, surgery has to be definitely done, maybe released. So we did the release of the ureteric stricture and reimplanted the ureter along with the help of urologist, excision of the endometriosis, and we also gave her a intrauterine device with GnRH. Because she was married twice, divorced twice, and severe dysmenorrhea for almost 8 to 9 years. So every treatment has an exception and every treatment has a contraindication. Surgery definitely comes to a rescue whenever there are problems, but kindly avoid doing multiple surgeries in young women.
Okay, madam. Thank you.
Yeah, Dr. Indira, please introduce Dr. Manoj Challani for the next lecture. Tulika CV of Dr. Manoj, sir.
Welcome to the session, sir. Dr. Manoj, he is the past president of Raipur OBG Society. He is the chairperson of CIGSR Directive 2024. He is the president of Raipur Menopausal Society also. He has worked as a vaginal surgeon of India. He is a member of the vaginal surgery secretary, and he is the founder secretary of IHFC Chadagiri chapter, and he is the vice president of IME Raipur. Sir, welcome to the session, sir.
Thank you. Thank you so much, ma'am, for the kind introduction. So at the outset, I would like to thank VOGS and Dr. Sadhna Gupta ma'am, Dr. Shadajan ma'am, and Dr. Ambuja, Dr. Hara sir. And we had a wonderful talk by Dr. Hara sir, Dr. Sadhna Gupta ma'am, and Dr. Queen Aditya, and just now by Dr. Asharam ma'am. So after the stalwarts, it's my turn to speak on urinary incontinence. And so this is, as we all know, the urinary incontinence is the loss of bladder control with involuntary involuntary urination and loss of urine. And there are different types of incontinence. There is stress incontinence, urge incontinence, mixed incontinence, which is stress and urge incontinence. Then there's the overflow incontinence and functional incontinence. And it's more common seen in women than in men. And it's more prevalent in older people than in younger people. And when we look at the types and causes, stress, it's stress incontinence caused because due to increasing age, because of vaginal delivery, pelvic surgery, menopause, and smoking. Urge continence because of overactive bladder and detrusor muscle overactivity is there. So it's causes because of it's idiopathic or detrusor muscle instability. There may be a CNS lesion. There may be a bladder neck obstruction, cystitis, again increasing age and obesity. And when we look at the causes of overflow obstruction, is caused by the urinary retention, sorry, because caused by the impaired detrusor contractility. And again, the causes may be diabetes, CNS lesion, and multiple sclerosis. And functional, when we talk about the functional urinary incontinence caused by environmental barriers to toileting and physical impairments. So maybe like, the women have to hold urine for a longer time, the toilets are not available, this thing. When she's doing it frequently, then it may lead to the urinary incontinence. And when we look at the stress incontinence, it's an involuntary urination or loss of urine occurs with situation of increased intra-abdominal pressure. Whenever there's an increase in the abdominal pressure, it may be because of the coughing, sneezing, or lifting heavy things, heavy objects, while laughing and exercising. So it may lead to stress, this incontinence. Urge incontinence, there's a loss of urine occurs with sudden urge to urinate. There's always, she empties the bladder, she comes back, but still again she has this urge to urinate. And when she goes, hardly there are few drops of urine are there. So there is urinary urgency is there. There's an increased urinary frequency, and nocturia is also there in this case. And when we talk about the overflow incontinence, there's an involuntary urination, loss of urine with full bladder. There's difficulty in urination. There's a urinary straining or poor emptying of bladder. And a mixed incontinence, as I already said, a mixture of stress and other incontinence features. So both features are there. Stress urinary incontinence is very common. So we'll talk more about the SUI. And stress urinary incontinence, as defined by the International Continence Society, is the complaint of any involuntary loss of urine with activity causing increased abdominal pressure like sneezing, coughing, laughing, climbing stairs, footing activities, etc. When we talk about the management of SUI, we should concentrate on non-surgical first, then we should move to surgicals. A non-surgical lifestyle modification is very important. We should advise the patient for the weight reduction. She should avoid taking caffeine and she should stop smoking. Then there's a Kegel exercises we all know, and that can help her a lot. We have to advise our counselor regarding the bladder training. Then there are drugs and other devices, and bladder drill and biofeedback are always there. All women with bothersome SUI should be offered non-surgical options first, and surgery is reserved for women who decline or fail non-surgical therapies. Where we have got the surgical option, open abdominal retropubic suspension, that is called, for example, colpo suspension by Burch, Marshall multi crans surgery is there. Then there's a laparoscopic retropubic suspension. We'll be talking about the vaginal anterior repair, that's anterior colporrhaphy, example, Callis and Passing. Then we'll be talking about the suburethral sling, including traditional suburethral slings and minimal invasive sling operations. Needle suspension, these are very old surgeries, which was like introduced by the Pereira and Stanley. Then we have got the periurethral injections and artificial instinctors. So when we look at the recommendations, tension-free vaginal tape and transobturator tape have got the grade A recommendation, as well as the open abdomen retropubic colpo suspension. So we have, before the surgery, we have to do the evaluation of the bladder. we have to do the evaluation of the patient. In the initial evaluation of the patient with stress urinary incontinence desiring to undergo surgical intervention, physician should include the following components. Prenatal history should be taken, including assessment of the bladder, physical examination, including a pelvic examination, objective demonstration of stress urinary incontinence with a comfortably full bladder, and assessment of post-void residual urine, and urine analysis should be done. So what is the indication for a urinary dynamics before surgery for SUI? Urinary dynamics should be done in cases associated with neurological disease, or if there is a history of radical pelvic surgery or radiation, or there is a previous failed anti-incontinence procedure, or when we see the post-void residual urine is more than 150 ml, and also in cases of mixed urinary incontinence. So when we are talking about the retropubic colpus suspension, all the procedures, different types, they've got the different transfixation type sites. Like in Marshall Machete trans, it's transfixion is done at pubic symphysis. Bursch colpus suspension is done at iliopectineal ligament, and paravaginal, which is useful in lateral and vaginal defects, which is of course less affected than Bursch. It's the transfixion site is arcus tendinous, and in vaginal obturator shelf (BOS), the obturator fascia is used for the transfixation. When we are talking about the Bursch colpus suspension, there are 4 permanent sutures are used. As you can see, 2 sutures are placed at the level of the mid-urethra, and 2 sutures are placed at the level of the bladder neck. And all sutures are passed through the Cooper's ligament, and high cure rates utilizing 4 sutures instead of 2 sutures. Bursch colpus, when we see the evidences, it has got a 70% cure rate at 5 years. There's few complications like bladder injury, which is 0.4 to 9.6%, post-operative hematoma transfusion, urinary tract infections, long-term dyspareunia, and post-operative enterosteal. So these are the few of the complications which can occur in Bursch colpus suspension. We should be very, very careful. So there are 2 types of suspension: transabdominal or laparoscopy. And in transabdominal, advantage is that there's excellent exposure and access. So we can easily access it. Long-term data supporting its durability and opportunity to repair coexisting abdominal pathology. But there are certain disadvantages, like there's a need of large incision, and the prolonged hospital stay and recovery period is also long. So when we look at the laparoscopic Bursch colpus suspension, it's a miniature abdominal incision is required, decreased post-operative pain and recovery, there's decreased post-operative voiding dysfunction, reduced blood loss, as in cases of all laparoscopic surgeries, and of course there's a short hospitalization stay. But the problem is the surgeon should be very experienced in this, and it takes the operative time is more in laparoscopic Bursch colpus suspension as compared to the transabdominal Bursch colpus suspension. Do not offer laparoscopic colpus suspension as a routine procedure for the treatment of stress UI in women. Only an experienced laparoscopic surgeon should perform the procedure. So now when we talk about the sling surgery, it's basically supporting the urethra and the bladder neck in a hammock. So elevation and partial compression of urethra is there, and there are various slings can be used. There may be autologous, heterologous, or synthetic. Autologous fascia lata can be used, or rectus fascia, vaginal patch, or gracilis muscle. In case of heterologous, proxy dermis is used. In synthetic, we get nylon tapes, muslin mesh, and gauze tags. So, and the results are good. We get the almost 80% cure rates, and traditionally result for recurrent incontinence or cases complicated by ISD can be considered for surgical treatment of primary SUI, and they may have certain short-term complications like bladder infection, overactive bladder symptoms, wound seroma or infection, or continued voiding difficulties, and there are certain long-term complications also which we should be careful of, like procedure failure, overactive bladder symptom, or voiding dysfunctions. When we are talking about this autologous rectus fascia pubovaginal sling surgery. The incision around 8 to 2 centimeter area marked over the rectus sheath. A strip of rectus sheath taken and a sling is made. Proline suture tied to ends of the sling and dissection done vaginally and sling placed at the mid-urethral level. And end of the sling with the proline suture brought out in abdomen and tied to each other. This is the way how it is done. So the success rate at the end of the 6 months is almost 100%. And most common complications are urinary retention and require prolonged catheterization, which can occur in around 40 to 50% of the patients. When we are talking about the synthetic mid-urethral slings, there can be synthetic retropubic slings, there can be synthetic transobturator sling, and it can be synthetic single incision sling. So these are the 3 types of synthetic slings which are used. And when we are talking about the tension-free vaginal tape, there's a continence at the level of mid-urethra, retropubic mid-urethral slings are used. Self-retaining knitted, these are the self-retaining knitted proline meshes there, and tape not suture to any structure. But there are 2 types of techniques, downside up and upside down. So do not use the top-down approach except as a part of clinical trial. And it has rapidly gained widespread acceptance because the short hospital stay and early return to work. The success in cure rates are similar to birth, and cure rates are almost 90% over 5-7 years, and have the similar success rate in mixed incontinence. So statistically significant and clinically relevant long-term improvement of quality of life after TVT is seen. There are certain complications of TVT like bladder perforation, retropubic hematoma. There may be, exposure of permanent sling material, delayed complication, and of course, vessel injury and bowel injury are comparatively rare in this. So it is quite safe, and learning curve is also less in this case. And when we are talking about the transobturator mid-urethral sling procedure, tape passes through the obturator foramen, and you can see the specially designed helical passes. Passes are there. The accurate, quick, and simple procedure, less risk of damage to urethra and bladder, and but there is a risk of damage to obturator nerve and vessels. So we should be careful about it. And in these cases, there is no need of cystoscopy. And this technique was introduced in 2001, and there are different there are various methods, but the principle is same in all the techniques. And success rate is very good and can be placed by inside out or outside in. You can use either of the techniques, and there are few complications. Damage to the obturator nerve and vessel is very important. As already said, we should be very, very careful in doing it. There's a mesh exposure, there's a bleeding, hematoma formation, urgency, and bladder infection, which are not very common, but still there. Then there's a single incision sling or mini sling, as it's called. It's a modification of TOT, and there's no passage through full thickness of transobturator space, resulting in reducing the risk of leg pain from obturator neuropathy. Not to be used except for trial as suggested by NICE guidelines. Then we are talking about the RCOG mesh safety alert. It was published in 2018, but the Indian government has paused the use of mesh for the SUI and prolapse surgeries. We are talking about the anterior colporrhaphy with Kelly's plication for prolapse with mild GSI, plication of paravaginal and paravesical fascia at bladder, neck, and proximal urethra is done. And though the failure rates are quite high, but there's no significant difference was seen between TOT procedure and anterior colporrhaphy with the Kelly's plication. And needle suspension, as already told, this is a very old technique, and it was Pereira and Stamey were the first to do it in 1959-1973. In this, suture sticks to above anterior abdominal wall and below the paravesical fascia, and outcome are quite good and may be used in prolapse with moderate GSI, but it's not recommended by the American Urology Association. Then we are talking about the paraurethral bulking agents. They are co-opting urethral mucosa, increased urethral closure. Pressure is there and suitable for women with ISD. Transurethral, periurethral injection of Teflon, Gex collagen or micronized silicone rubber particles are used, and there may be urinary infection, obstruction, erosion, hypersensitivity to the collagen can occur. So we have to see whether our patient is sensitive to this or not. Particularly useful after failed surgery, radiotherapy, scarred and fixed urethra. And when we are talking about the artificial sphincter, inflatable cuff placed around urethra to provide occlusion and a reservoir to allow deflation, can be used as the primary procedure in women with ISD, and cuff erosion and mechanical failure are the major problems in these. But it's not recommended by the NICE. So the last use of stem cells for SUI, transurethral USG cardiac injection of autologous myoblasts and fibroblasts obtained from skeletal muscle biopsies are used. The fibroblasts are injected into the urethral submucosa while the myoblasts are implanted into the sphincter. Long-term post-op results in larger number of patients needed to be assessed that the injection of stem cell could become a standard treatment for SUI. So still a long way to go, but we have to keep watch it. And thank you so much for the patient hearing. And please don't forget to nominate me and vote me for the Medical Disorder in Pregnancy Committee, FOXY. And thank you so much. And thanks to VOJs for inviting me and interacting with all of you. Thanks a lot.
Thank you very much, sir, for giving a good knowledge about the stress incontinence. And previously, we used to do a little surgeries and urethral problems, urine bladder problems. But nowadays, because of the urology is so developed, they're doing all sorts of surgeries. Especially in government general hospitals, we are all referring all the patients who need surgery to the urology department. Thank you for giving a good knowledge about the incontinence. Thank you.
Thank you, ma'am, and all the best to Sadhana Gupta, ma'am. Best wishes, man. Best of luck. You are muted, ma'am. You are muted.
I thank my chairpersons, Dr. Susila and Dr. Indira, for chairing the two sessions. We'll go ahead with session 3, which is the panel discussion. Before that, I introduce my chairpersons, Dr. V. Padmaja. A slide, please. Yeah, she is the past president VOGS, founder chairperson AP chapter of ISAR, presently consultant Padmaja Clinic, Vijayawada. She worked as secretary Epoch Society in 2017 and an organizing co-chairperson South Zone UFOXY in 2018. She is a fellow of Indian College of Obstetricians and Gynecologists and an excellent teacher. Dr. Lata, slide please. Dr. K. Lata, who graduated from Guntur Medical College and postgraduated from Rangaraya Medical College, Kakinada, has been a faculty and in presentations on various topics in APCOGs and UFOXY, and has been part of the organizing team which conducted APCOG 2015 and UFOXY 2018, and held several posts in executive body of Vijayawada, and she is the past secretary Vijayawada Society. Welcome, Padmaja Madam and Lata Madam. I hand over to you.
Thank you. Thank you, Dr. Shailaja, for such a wonderful introduction. I thank the organizing team for giving us the opportunity to chair this session. I congratulate once again Dr. Sadhana Gupta Madam and wish you all the best for the coming elections. Coming to the panel discussion today, which is being moderated by Dr. Nisha Gupta.
Dr. Nisha Singh.
Yeah, sorry, Professor Dr. Nisha Singh. She has been the unit head and in charge and genital cancer control unit, King George Medical University, Lucknow, fellow of ICOG, secretary of UP chapter, AGOI, secretary of Lucknow OBG Society, treasurer, joint secretary, and executive member of UP chapter IAGE, master trainer for 2 international, 30 national and state trainings. She has many awards on her name. Asia's Top 50 Academicians, EET CRS 2021, Sushan Chikitsa Seva Gaurav Samman 2019, Best Paper Award FOXY 2010, Best Faculty 6th Academic Brilliance Award EET CRS 2018, Bharat Jyoti Award IIFS 2015. And she has done her undergraduation from LHMC, post-graduation from AIMS Delhi, Gynec Oncology Observership from Stanford University, USA, Barts Cancer Institute, London, RUH Canada, TMH Mumbai, endoscopic training from AIMS. She has many publications on her name and chapters, almost 8 in number. She has been a speaker for more than 160 topics. She has been a reviewer of 17 journals and organized annual conference of AOGIN India 2017 and many CMEs also. I would like to give a short introduction to all the panel members also. Tulika, would you please, Dr. Shailaja Pinjala.
Lata madam, Dr. Shailaja madam is sick. She is not available. We'll go ahead with the next scene.
Okay. The next speaker, the next panelist is Dr. Aruna Vidupalli. She did her undergraduation from AMC Vizag. She post-graduation from JJM Medical College. She has special trained in laparoscopic surgeries at Dr. B. Ramesh, Bangalore, and she runs Snehalata Hospitals. She has been the managing director of Snehalata Hospitals, and she belongs to Anantapur Obstetrics and Gynec Society. She organizes many free medical camps in surrounding villages of Anantapur district. She conducted many CMEs also as president of Foxy Anantapur. Next slide. Coming to Dr. Sumati, she is the senior consultant Anantapur at RDB Battapalli, Anantapur. She has been the past assistant professor of Shantiram Medical College, Nandyala, member of OBG Society from 1975. She has been the life member of Indian Medical Association, life member of Academy of Medical Specialities, and her main interest is alternate healer in Reiki, kinesiology, and Siddha healing. Coming to Dr. Uma, she did her undergraduation from Tirupati and post-graduation from Jipmar Pondicherry, undergraduation and post-graduation from SV Medical College, Tirupati. She did a SR from Jipmar Pondicherry. She has been working as professor and unit head at NRI Medical College, and she has many research publications in various national and international journals. Dr. Achila Sahai Sharma, she is the professor of GR Medical College, vice chairman of IMA WDWMP State Branch, joint secretary AMPOG. She has been awarded as a Times of India Health Icon Award 2021. And she is the master trainer cervical cancer screening and pre-cancer treatment, NHM Madhya Pradesh. Dr. Nagamani did her undergraduation and post-graduation from Kannur Medical College, and she runs 50-bedded multi-specialty nursing home and has a vast experience of 24 years. She has experience in conducting all types of gynec and obstetric surgeries and laparoscopic surgeries. And one important thing, she promotes free education for meritorious students every year of almost equal to 5 lakhs. I think all are there. Over to you, Dr. Nisha.
Yeah, thank you so much. A very good evening to all, good morning to all of you. And I welcome you all. And I thank Dr. Sadhana Gupta for giving me this opportunity and also being able to present this panel discussion in front of such stalwarts that we have been listening to since the morning. So I welcome all my
One second, Nisha madam. I request all the panelists to on their videos, please.
Yes.
And Nisha madam, you have 45 minutes. I'll remind you 10 minutes before.
Yeah. So can you see my slides?
Yeah, madam. Can you put the slideshow?
Yeah, I'll just do that. And I was not aware that Dr. Shalja is not there. So
she put up a message at the last moment, madam. She's
no
getting tested today. She has
the only thing is that some questions that I have written with her name, I'll ask anybody to volunteer for them.
Okay.
Okay. So we'll be talking about the abnormal uterine bleeding across the ages. Welcoming all the participants. Now, abnormal uterine bleeding, we know that the worldwide impact is such that there's a prevalence of 3 to 30%, higher in the adolescents and the 5th decade. In India also prevalence goes as high as 17% plus. And most common, this would be the most common cause of patients coming to our gynae OPD, and also a very common cause of hysterectomy. So I would like to just mention about the FIGO nomenclature that came in 2011, the new classification about both the symptoms as well as the causes. And so I would like, most people are aware about it, the academicians, the people who have been talking about it. But if you think about the practice part, people are still not using this nomenclature. The causes one is more commonly used, the palm coin, but the symptom classification has not changed that much. So we'd like to highlight that. So this question, though I had put for Dr. Shailaja, I would like any one person to just discuss the FIGO system 1, that is the nomenclature of normal and abnormal uterine bleeding, the symptoms, how the names have changed from the common names that we used to have, the terminologies like menorrhagia, oligomenorrhea. What do we have now? May I ask Dr. Achla to talk about this?
Yes, thank you, Dr. Nisha, to give me this opportunity to be with so many best speakers of our country, I must say. Thank you so much, Sadhana, madam, and all the best to you. Madam, I just, because it's just that the normal uterine bleeding, as much as we can say, is that the term metrorrhagia was removed from the terminology, and we came to this intermenstrual bleeding, which occurs between the 2 cyclic periods or the menses of a woman. And besides giving the importance to the frequency and duration, the regularity was also taken into this thing consideration, and the amount or the volume of the blood, it was also taken into consideration. Also the bleeding which was because of HRT or giving exogenous estrogens, they were also taken into this thing, and they were also added. And if it was just taken that whether HRT is being given or not given, that's it. This much I can add on this.
So I would just like to, because we are short of, we have to complete it in 45 minutes also. Yeah. So the important thing is that now, when we initially we used to say 21 plus minus 7 days, that was the duration of a normal cycle. Now we, according to this classification, we have 24 to 38 days that is considered normal. So anything less than 24 is a short cycle, and we call it, the cycles occurring more frequently. So we have frequent and infrequent cycles now. So less than 24 is frequent cycles, more than 38 days is infrequent cycles. Similarly, for the duration, now we have normal, anything that is up to 8 days is normal, but more than 8 days is prolonged menstrual bleeding. Then we have heavy, light, according to the patient's perception. So normal, so any amount of flow that the patient feels is abnormal. She says it is lesser than the normal, it's a light bleeding, it's more than the normal, it's heavy bleeding. And intermenstrual, as you said, and which could be random, which could be cyclic also. The 2 other terms that we have are the acute and chronic bleeding. So chronic bleeding is something which has been present for the majority of the last 6 months, and acute, it's something which is according to the clinician, where the amount
immediate interventions
is sufficient to require immediate intervention. The point to learn is that we learn these new terms, the acute and chronic bleeding. We learn heavy and light menstrual bleeding. We learn prolonged menstrual bleeding, which is more than 8 days. And we learn frequent and infrequent cycles. Let us unlearn the terms menorrhagia, polymenorrhagia, oligomenorrhea, and TUB. Now, coming to the second question, which goes to Dr. Aruna, just describe the palm coin classification, which is an etiological classification, but since 2011 to 2018, there have been minor changes. Dr. Aruna, please. Do we have Dr. Aruna around?
She's around, ma'am. Dr. Aruna? Can somebody else take the question, madam? I'll just call her. She is logged in.
No problem. So anyone who can just talk about these changes in the FIGO cause classification, the system 2, the palm coin.
Dr. Uma, you please take the question. Meanwhile, I'll call Dr. Aruna.
Unmute.
Yeah, madam, sure.
Please go ahead.
This second classification, palm coin classification. First one is polyps. Polyps include the same. It remains same actually, like it might be an endocervical or endometrial polyps. Next one is adenomyosis. This is depending upon the morphological appearance of the uterus on transvaginal ultrasound. They have 8 criteria.
We'll talk about that
I
later.
think we are going to discuss
Yeah.
later. Yeah. According to that, we can go, and where you are not sure by TVS, then only we are going to consider MRI.
Correct.
Next one is leiomyoma. Leiomyoma, it is they have now 8 subclassification. First one is like a first pedunculated submucosal fibroid, and another one is submucosal fibroid. These two can be differentiated by using how much pressure it is needed to be visualized. Next one is less than 50% is intramural. Less than 50%, more than 50% is submucosal. 2 is more than 50% is intramural. 3 is a new one now. This is intramural, but touching the endometrial lining.
Correct.
So we can expect heavy menstrual bleeding even in this subtype 3 also now. And next, fourth one is completely intramural, which is not in attached with either serosa or with the endomet lining. 5 is more than 50% is intramural, very small amount is subserosal. 6 is greater than 50% is subserosal, less than 50% is intramural. 7 is subserosal. 8 is elsewhere, I mean other sites. Another new introduction is 2-5 they have given. That is, it is an intramural but touching both the endometrium and the serosa. Okay. These are the things.
Yeah, so major change has been that now the type 3, which was just indenting it is 100% myometrial, but it indents the endometrium, has been taken as a, crossover thing. That is, it may be a cause of AUB, and it may be managed hysteroscopically. So that's, and then about the stalk diameter, which helps us differentiate which will be called as pedunculated and which will be called non-pedunculated. Yeah.
Less than 10% of the total value.
Correct.
And AUB, M malignant and pre-malignant lesions, they didn't change much. C for coagulation lesions, coagulation disorders. If it is because of any drugs we are using, especially antipsychotic drugs which impair the coagulation, now they have moved from C to iatrogenic. O is ovulatory dysfunction, any endocrine disorders only included, not that drugs which cause ovulation disorders are not there here. Endometrial causes, it might be one of the important region might be chlamydial endometritis. Iatrogenic, any drug causing coagulation abnormalities are in iatrogenic. N is other not yet classified, like AV malformations, etc. are included in the N.
Yeah, thank you so much, Dr. Uma.
Thank
you, with this classification, now we'll go ahead to the questions, the case-based discussions. So case 1, may I ask Dr. Sumati to respond to this? This is an unmarried girl, just 16 years. And because the topic is across the ages, I will go increasing the age and the problems. So presenting with heavy menstrual bleeding since menarche, and this time she comes with bleeding and weakness since 15 days. So what are the important points to be considered in this young girl who's presenting with this abnormal bleeding? Dr. Sumati, please. Do we have Dr. Sumati around?
Yeah, madam, she was logged in.
May I request all the panelists to keep themselves unmuted and the video also on?
I have severe cough. You may not be able to listen, hear me because I start.
It's okay, ma'am.
We can hear you, madam, loud and clear.
Okay. The unmarried girl from the menarche, from the time of menarche, she had hypermenorrhea or the heavy menstrual bleeding, and with no history of, we want to know whether she had any amenorrhea previous to that, and if the cycles were regular or irregular, and blood loss estimation, how much of the blood was lost at every period, and prolonged bleeding, if she had any surgeries or any interventions, and whether she is sexually active, and family history of coagulopathy and hormone sensitive cancers, and drug intake, if she is on any drugs that she is using, ossipils. So, and examination and all these things are important. And general physical examination, the amount of blood loss will be indicated by the pallor that she is having. And also petechial hemorrhages and bruises will point towards the hematological disorders. And thyromegaly may show thyroid problems. And if at all she has galactoria, it may point to a tumor in the pituitary sometimes, which is a rare problem. And another thing is acne and problem of hirsutism and all that, because most of the youngsters, they are having PCOS. This will be one of the factors. And then coming to the investigations, she has to have complete blood count with peripheral blood smear to exclude sometimes of leukemia.
Tulika, please mute the other participants.
To know the serum ferritin levels and tetramen.
Yeah, please go ahead. Dr. Sumati.
Dr. Sumati is muted.
Yeah, I'm
yes, you are heard.
Serum fibrinogen and fibrinogen degradation products also are needed. Serum TSH, serum prolactin, liver functional tests and pregnancy tests, and recurrent history of malaria also sometimes when her hemoglobin level goes down, and with splenic enlargement also sometimes can cause bleeding, heavy bleeding, HMB. So all these things are needed. And another thing is adolescents usually they can have van Willebrand's and factor antigen and cofactors and the blood dyscrasias. And another thing is HPO axis. The development of HPO axis is very, very important. And without taking that into consideration, we cannot put her onto any medication like ossipil.
Yeah.
So that.
Yeah, so important point about puberty-related AUB is that if it is heavy menstrual bleeding, then it may be related with coagulopathies. We must rule them out. And if it is infrequent cycles and all, then the HPO axis and the PCOS become the more common presentations. So, Dr. Uma, I would like you to highlight the management points for acute bleeding when these patients are coming, because she is bleeding for 15 days. So what are the options that we have to control this bleeding? And
yeah. Okay. Acute bleeding is a bleeding which needs an urgent intervention. Okay. She might have previously had similar episode, may or may not be, or previously she might have a heavy bleeding, but of a small quantity. But now this is so heavy, she needs an urgent intervention. If you take a case of any cause of heavy menstrual, cause might be anything which can cause a heavy menstrual bleeding. And 20% of coagulation disorders are responsible for heavy menstrual bleeding. So we are so already we have discussed about how to investigate and all these things. I don't want to stress into it. A urine pregnancy test, because we are doing in a reproductive age girl, first rule out that and we'll proceed with other investigations. So initially when the patient comes to us, just see whether the patient is hemodynamically stable or hemodynamically unstable. Okay, if she is hemodynamically unstable, we go in lines of management initially, put 2 large bore IV needle, start crystalloid, along with that collect blood for all investigations needed, send blood for urgently. We may start with the crystalloids, but we have to get blood and blood products ready for that. Okay. Next, to stop immediate bleeding, we'll take like 2 things. In case detailed clinical examination and history taking is very important. In history taking, I want to emphasize, as we are talking about adolescent girls, coagulation disorders, structured history taking, we can get around 90% of coagulation thing. That order is very important
Dr.
for us.
Uma, I think most points were highlighted. If there is something extra you can add, otherwise highlight the management part, please.
Thinking in lines of coagulation, first we start with tranexamic acid, 1 gram, IV, PID or QID, followed with conjugated ethinyl estradiol, 25 milligrams intravenously, again 4 to 6 hourly. This will help to arrest the bleeding almost within 8 hours, but continue it up to 72 hours. Always we have to again support these estrogens with combined oral contraceptive pills, which contains 35 micrograms of ethinyl estradiol in a tapering dose. Like 1 TID to later we can gradually decrease. Otherwise, you can start with high dose progestogens like medroxyprogesterone acetate 20 milligrams thrice a day. Again, go ahead with a tapering dose, or norethistone acetate 5 to 10 milligrams TID in a tapering dose. We can go. If we are suspecting coagulation disorders, then we have to replace 1 millibrand factor and factor 8 recombinant. If these two are not available, then go with desmopressin, which is synthetic analog of vasopressin, intranasally 300 micrograms TDS. So we can go. If a patient is anemic, go ahead with the blood transfusions. If not, then after once the bleeding has stopped, they can supplement oral iron therapy. Whether manage these patients, inpatients or outpatients, once the acute episode is over, you can send the patient to home and you can treat them in an OPD basis. There is nothing wrong in it.
So I
want to only emphasize one thing here while we are drawing for blood for coagulation profile for 1 millibrand screening. Better to know whether patient is taking any other hormone, because they are going to derange the 1 millibrand factor panel. We have to consider that. Otherwise, it's okay. Yeah.
So thank you, Dr. Uma. So the point is that there are many medications available. We have to just decide what is available and what are the maximum doses that we can go to. And previously, I remember that equine estrogen was more often used, but nowadays with the progesterones and the tranexamic acid, most of the cases are well managed, and only in the coagulopathy cases we'll need the special drugs. So this is one of the algorithm that is there, that after we have diagnosed that this patient has coagulopathy AUB, in consultation with the hematologist, we have to give the medications, and the initial management and then the long-term management will mostly be going on to some of the hormonal therapies, and we have to, in case
Sorry to interrupt you, Dr. Nisha. Dr. Aruna has logged in. She logged in the delegates link by mistake. She's around now.
So no problem. I think we'll go ahead with the next case.
Yeah.
So this is a case for Dr. Achla Sahai. Dr. Achla, there is a 22-year-old woman. She is para 0+0 married woman. She has history of infrequent cycles and light bleeding for 6 months. And she also complains sometimes of dull aching pain for 1 month. And she also wants to get pregnant because she is para 0+0. How will you approach this case? Dr. Achla, are you there? Dr. Achla, are you there?
Now I think you can hear me.
Yeah, Dr. Achla.
Yeah. So we need to understand the DD in this patient. And as per the patient profile, she could have hypothyroidism, she could have hyperprolactinemia, she may have COX-2, she may be pregnant, and she may have intrauterine adhesions. So history taking and a thorough examination are very important, as we need to know about any history of weight gain or weight loss, loss of appetite, if there's any history of evening rise of temperature or hair loss, or there's a history of COX in her relatives, or she herself has a past history of COX. Also, if she initially had prolonged heavy bleeding episodes, because COX may at times lead to increased prolonged bleeding because of endometrial congestion and edema initially. A thorough examination in which we will do a general examination for the nodes to see the lymph nodes, an examination of the chest, a bimanual examination to rule out any pelvic lump or tubo-ovarian mass is required to investigate her. Apart from her complete blood picture, we will go for a ESR and a complete thyroid test, that is TSH, pre-T3 and pre-T4. Serum prolactin will also be done. A PPD test or the Montoux test should be done, though it is quite non-specific. We'll go for a urine pregnancy test and X-ray chest PA view to see if there is any evidence of pulmonary TB. Then we'll do a pelvic ultrasound and preferably a TVS to get an idea about the endometrial thickness, tubo-ovarian masses, to rule out the PCO and if SAC, if at all it is there. At times, we can see a cogwheel sign of hydrosalpinx and the intrauterine adhesions also. We will go for a premenstrual endometrial biopsy then, or aspiration. And on this, we can go for CBNAT, PCR, gene expert to have a diagnosis of COX, or we may have a diagnosis of LPD, the luteal phase defect. And after that, we are also having a hysteroscopy with us to evaluate these patients. But if at all these patients have, endometrial COX, then the cavity may be shrunken, and it is risky to do hysteroscopy in these patients. It should always be under along with the laparoscopy and done by an expert only. And if we do a hysteroscopy, we may get evidence of caseous tiny nodules and a pale endometrium. We can at the same time test the tubal patency also. And after that, if we get an idea that this patient is having positive endometrial biopsy for COX, then we have to go for ATT in these patients. We go for a 6 months course. In the initial 2 months, we take 4 drugs. And
yeah, Dr. Achla, I think the point that we wanted to highlight was this only, that if they are coming with infrequent cycles, then these are the DDs that you rightly mentioned. One is the genital COX and the other is the luteal phase defects, the prolonged cycles that are happening. So so we must first do and try to rule out the FGTB, and if the EB is normal, then only we go ahead for the HSG or laparoscopy or hysteroscopy. But if it shows abnormality, we treat accordingly. And otherwise, if it is showing out of phase endometrium, then we go for
hormonal therapy can be given. Yeah.
Thank you so much.
Cycles.
Yeah. So talking about another patient, Dr. Nagmani, I would request you to take this one. 30-year-old para 2+0 coming with heavy and prolonged menstrual bleeding. Now, mind it that every time I'm putting up these cases, we understand that this is out of pregnancy. So obviously we tend to rule out pregnancy. We must practically do. So that will need not be said every time. Heavy and prolonged menstrual bleeding, and also minded that the terms that I'm using, they are the new FIGO terminology terms, followed by spotting for 6 to 7 days since last 5 to 6 months. Cycles are regular, not associated with pain. Somebody had done a PS and PV that did not show any abnormality, and then a TVS was done. It showed a thickened endometrium, thickening being 21 mm. So somebody advised her the medroxyprogesterone acetate 10 mg OD for 21 days cyclically, but she continues to bleed. Then what are your comments and suggestions? How would you manage, or what more could have been done at that time? Dr. Nagmani, are you there? May I have Dr. Nagmani there?
Yes, I am there.
Yeah, please.
I'm audible, madam?
Yes, sure.
Because of her parity and because of her age, and she has started already progesterones. First of all, we should think of endometrial polyp, and we should undergo routine investigations like hemoglobin, blood sugar, and thyroid profiles, and all those things. I will ask for ultrasound with Doppler. When there is no flow in Doppler studies, first we should think of polyp. And because we have already started her on medicines, but she's not getting response, first I'll go for endometrial sampling. Endometrial sampling via ultrasound guided, or we can go take it with hysteroscopy. hysteroscopy is a gold standard treatment that can give us diagnostic, and we can do endometrial curettage at that time. But in low resource settings, we can advise ultrasound guided dilatation and curettage and send for HPF examination, histopathological examination.
Yeah. So so the important point that I just wanted to highlight through this case is that one is that whenever there is when you're doing the TVS and it is a thickened endometrium, see up to 15-16 mm, it's okay. But if it is going beyond that, you may suspect that there could be a polyp which you are just seeing as thickened endometrium. That's one, and which will not be treated by your endometrial biopsy. Biopsy may come just normal also. So in these cases particularly, it is very important that the patient goes for a hysteroscopic evaluation, because that will be both diagnostic as well as therapeutic. You can remove the polyp at that time only. Second important point was that somebody gave her medroxyprogesterone, but the dose was only 10 milligram daily, which sometimes even when the polyp is not there may not be effective. So we have to give a higher dose of medroxyprogesterone acetate, which usually 10 mg BD or TDS will function better. So the treatment algorithm for polyps, when you are suspecting, then you do a hysteroscopic polypectomy. Single polyp, obviously you remove and the patient is perfect, she's all right. But if there are multiple polyps, then it's kind of a polypoidal endometrium, which may need, so the histopathology will give you further guidance regarding that. If it is normal, you can put her on some progesterone, maybe oral or intrauterine system. So coming to the next case, again, this I had planned for Dr. Shailaja, but any one of you can volunteer and take this. A 35-year-old Nalli Gravida with type 2 diabetes presents with heavy menstrual bleeding for last 2 years. Her TVS shows an intramural fibroid, which is 4 centimeter, indenting the endometrium. So it is a type 3, that the FIGO class 3. Yeah. Now, how will you manage this case? What is the role of endometrial biopsy? She is less than 40 years. And what is the role of hysteroscopy?
Ma'am, can I answer?
Yeah, please, Dr. Uma.
Yeah. She's 35 years young, so she still has to conceive. So we want to always, that management of fibroid depend upon the age and her fertility status, symptoms and all. So here we want to keep the uterus. And ultrasound shows a fibroid intramural but indenting the cavity. That's the reason it indents the cavity, which is presenting with heavy menstrual bleeding. And second, whether to go ahead with endometrial biopsy or not. She is with type 2 diabetes. Even a woman less than 40 years with a high risk factors, like high risk factor obesity, nulliparity, polycystic ovaries, hypertension, family history of endometrial, ovarian or breast cancers, use of tamoxifen, other hormonal therapy, all this requires an endometrial biopsy. First, in this case, we go ahead with endometrial biopsy. And then again, role of hysteroscopy, as now we are 1, 0, 1, 2, 3 also we can go ahead with hysteroscopy. So both hysteroscopy help us as a diagnostic and a treatment modality.
Right. Yeah, so it helps us to distinguish, and simultaneously we can plan the treatment also. Initially we do a mapping and then we treat. So this is just a small case of, I'll just show this video, that this was one case that we had treated multiple small fibroids in the cavity. There were 4 of them. Just the diagnostic part I'll show you, and then we did a hysteroscopic removal of this, and then the patient immediately after the next 2 cycles, she conceived, and she could have a normal vaginal delivery. So that was one. You can see the multiple, fibroids. I'll just cut it short here only, just to share it with you all. Now, coming to the next question with Dr. Aruna. What are the other uterine preserving treatment options? We talked about the hysteroscopic myomectomy evaluation and removal simultaneously. We have had a talk before this, so we'll just make it very short. And any comments about the comparison of their efficacy? We heard from Dr. Queen Aditya. Yeah.
Yeah, madam. Thank you, Dr. Nisha. And these AUBL uterine sparing options. First one is myomectomy. It may be open, laparoscopic or hysteroscopic, and LNG-IUS arena like the thing, and uterine artery embolization, HIF, high intensity focused ultrasound, MRI, and UST guided. Laparoscopic radio frequency ablation, and I think we can add this Ulipristol.
Right, the medical management. But okay.
GNR channel.
Yes.
And in comparing treatments, the reintervention risk after 36 months is 1.2% for abdominal myomectomies, and it is 7.4% for uterine artery embolization, 34.7% for high intensity focused ultrasound. It includes both MRI and ultrasound guided.
So the point that I just wanted to highlight, there are various options, but different patients will have different things suitable, and also the expertise of the surgeons, also the availability of the various options, the resource settings, so they will have an impact on your decision. And we have heard about the various medical options, also, but most of them are very temporary, treatments that are there and cannot go on a long way, especially Ulipristol. You said there have been reports of hepatic dysfunctions. We cannot give it for a long time, but Mifepristone was highlighted. So I'll not go into the details, but just telling an overview. Thank you, Dr. Aruna. So obviously, as I said, there would be different management protocols for the type from 1 to 8. We have the various.
It depends on age of the patient.
Yes, it will depend on the age, fertility, conservation, parity, and yes, desirous of pregnancy or
fertility. Size of the fibroid, site of the fibroid, symptomatic or not.
Yeah, symptomatic is very important. So unless symptomatic, to go for a surgery will not be very much appreciated. So we have to just see that how much is the need for a definitive surgery in this particular case. Yeah. So going to the next case.
It is very big. Also, it is sometimes we see about 40 centimeters, 15, 20 centimeters like that. Fibroids also we'll see. Then
we have to.
No other option.
Yes, we know that pressure symptoms and all would be there by then. Okay, but the important point here I would highlight that many times patients come to us and they are told that, they are told or they have a myth that will it undergo malignant change, so that we have to all understand that less than 1% would actually. So therefore, the urgency of the surgery or, you can give time, discuss and plan your management.
Yeah. If it is symptomatic, we have to think of all things.
Yeah, thank you so much. So going to
mucosal,
Yes, doctor.
If it is less than 4 centimeters, it can be removed by hysteroscopic myomectomy.
True.
And if it is more than 4 centimeters, by abdominal myomectomy.
Correct.
Intramural or subcerebral, if they are symptomatic. If she needs immediate conception and failed
So your voice is
failure, then we can go ahead. Yeah. I have a little cough and cold.
Yes, I can understand all of us. So going to the next case. That is for Dr. Sumati. We have a 40-year-old para 1. Dr. Aruna, can we go for the next case? Because fibroid in itself is a really big topic which we cannot cover in this panel discussion. So, Dr. Sumati, there is a 40-year-old para 1 presenting with heavy and prolonged bleeding, and somebody nicely did an endometrial biopsy, and the report shows atypical hyperplasia. She's 40-year-old. Now, what are the important points to be discussed during the counseling, and how will you manage? What are the options that you have to manage this? Dr. Sumati, are you there?
Yes. Yes.
Please.
So, as she is, I won't say perimenopausal, but she is in the second phase of her childbearing age. Risk of endometrial carcinoma, coexisting endometrial carcinoma is about 25 to 40%, because when they have taken a biopsy, it's not a guided biopsy. it might have missed the point where it is showing endometrial carcinoma. So the other place may be showing a typical hyperplasia. So we should make sure about that. And when we are going to enlighten her about all the procedures that are in the armamentarium, we should say with a typical endometrial hyperplasia, there may be a chance of endometrial carcinoma which can progress. And it is going to be a different problem to say that if she wants to conserve her uterus, it is going to be a very difficult problem. So, though the surgical management is the best, if she wants to conserve her uterus, it may be offered. Sometimes when it is LNG IUS will also be helpful.
Right.
So as it will help, and she can have the menstrual bleeding may get controlled, and slowly the changes that are in the endometrium can get reversed, because the endometrium is responsible, it responds to the progesterone that is there in the LNG IUS.
Right. That is the first choice. Somehow missing from the slide. I'm sorry for that. But definitely LNG IUS is the first choice for atypical also.
First choice. And it should also include the risks and benefits of both medical and surgical management.
Right.
So MPA 10 milligrams TDS or Progesterone estate 80 to 160 milligrams can be given continuously for 3 to 6 months, so that pseudo pregnancy is induced where there will not be any changes in the endometrium. Showing this, when you put continuous progestational therapy, there will be changes which will not go according to the endometrial hyperplasia. So a typical hyperplasia may be controlled and she may come back to normal after 6 months, and we can check again. So doing the transvaginal ultrasound and see the endometrial response, how much it is, and also take a pipple biopsy and see, or take the opportunity to do a hysteroscopy. Excuse me.
Yeah, so very rightly said, Dr. Sumiti. So if there is atypical hyperplasia, we can treat it by LNG IUS or medical management if the patient insists on that, and she's, fertility sparing kind of treatments can be given. And another question I would ask, it's not written there, do we include the leiomyosarcomas also in the M category?
I don't think.
No, we do. We do. Yes. So point is that M category includes all malignant and pre-malignant lesions, right? Yeah. So, all right. Going to so this is a treatment algorithm that we have for AUB-M, that is the hyperplasia with or without atypia, and then if it is malignancy, obviously we'll go for the further treatment. Yeah. So coming to the next question, to Dr. Uma. This is Mrs. X para 3L3 at the age of 45 years. And she presents with heavy menstrual bleeding and dysmenorrhea also since 9 months. When the examination is done, uterus is around 12 weeks in size. It's a little tender, though mobile and firm in consistency. Fornices are clear. Let's discuss what will be the differential diagnosis and what tests would you like to do?
Yeah. Yes, if it is my undergraduate question, I'll carry with only 2 differential diagnoses like leiomyoma and fibroid. But now, as polyps also, I can't rule out as it is an hyperestrogenic, both adenomyoma and leiomyoma. Next year, adenomyoma, leiomyoma, malignant and pre-malignant changes I want to rule out. Unlikely, 45 years old, so I'm not thinking about a coagulation disorders. Ovulatory, I want to rule out ovulatory. Iatrogenic, history telling that there is no usage of any drugs, so I don't want that. And endometrial, definitely I want to. Non-specific, hope so, nothing should be there. So for the first, for the test, after doing all other investigations, for me, clinical examination, uterus is 12 weeks, it is mobile, mild tenderness is there, fornices free. Yeah. So before going to TBUS, always prefer to do transabdominal ultrasound followed so that I can get an idea about the adnexia also.
Yeah.
Then proceed transvaginal ultrasound. Transvaginal ultrasound help us to know how is the endometrial cavity, whether there is a polyps or thickening of the endometrium. Intramural lesions, either leiomyoma or adenomyosis. Ma'am, we go in depth with the adenomyosis criteria of diagnosing adenomyosis here.
In the next, yeah.
Next,
So
okay.
important is that endometrial biopsy after 40 years of age, if they are presenting with abnormal uterine bleeding, should be done. So that we will definitely plan. Whether it is a blind or a guided will depend upon the TBS findings. Yeah. So now coming to Dr. Achla for the sonological features of adenomyosis, because that's an important addition in the FIGO criteria of diagnosing adenomyosis. And they have said that even the transvaginal sonography is good enough to make this diagnosis. So let us hear about that from you.
Yes, I agree to it. And I think a high suspicion for adenomyosis in patients who have excessive bleeding during menses and chronic pelvic pain has to be there, especially if they have high estrogen exposure, high BMI, high early menarche and short cycles. So the ultrasound findings are due to 3 reasons. There could be ectopic endometrial glands and stroma 1. There could be the muscular hyperplasia and hypertrophy, and there could be the increased blood flow to the tissues. And accordingly, either we get a mottled inhomogeneous myometrium with small spaces. The cystic spaces are there, and there could be diffuse enlargement of the uterus, and it starts appearing globular with small blind pencil-like shadows, the hypoechoic area, shaggy, indistinct endometrial strip because of the blurred endometrial border is there. And there's a pattern of penetrating blood vessels at the Doppler. This courses through the area of the adenomyosis, and by this we can also differentiate it from the fibroids, because there we see at the periphery. So these are few findings which will help us in diagnosing adenomyosis at ultrasound.
Yeah, thank you, Dr. Archana. So I'll ask Dr. Nagamani, what are the treatment options when you diagnose adenomyosis? Because it could be in the younger women also, it could be in the older women also. So
it depends upon the age of the patient. In younger women, we can try medical management, and when there is a bleeding, excess bleeding, we can try with tranexamic acid with mefenamic acid combination and medroxyprogesterone acetate, whether we can give continuous or cyclical. And in young age with nulliparous woman, we can go for, if she responds with tranexamic acid and mefenamic acid, okay. Otherwise, we can start letrozole or anastrozole continuously for 6 months. That gives like a perimenopausal state and perimenopausal hormonal milieu that gives adenomyosis lesions will get suppressed with the treatment. Otherwise, if she is a parous woman, we can try with levonorgestrel intrauterine device that at the nowadays young women are coming 30 years completed their family and coming with adenomyosis. We can LNG IUS is a good choice for them. We can give a symptom-free period and good quality life for them, and they will be very happy. And we can remove it after 5 years also. And another, if it is a local adenomyosis, we should go for a adenomyomectomy if she is an infertile woman.
Correct. So I think that very rightly said, and LNG IUS works well only in distorted cavities. There is a chance of expulsion, and this adenomyomectomy as a fertility preserving surgery has now come up for young women. More people are trying that out, and there are evidences, long-term series also. And so these are some of the techniques: the slice technique and the bisection and enucleation technique, then the triple layer closure. So these are some of the things that have been, if you go through the literature, and many people are have started doing these things. So removing the adenomyoma, just leaving about 1 centimeter of the normal myometrium outside. So it's just by the feel, because there's no capsule. It's just the hard tissue that needs to be removed, and the soft vascular myometrium, which is normal, needs to be left. So that can be tried nowadays. And although whenever needed, we have been doing it, but now it becomes, there are long series and people are reporting good response to these surgical treatments also. So for AUBA, this is the algorithm. I think we have already discussed most of the aspects. So Dr. Shalja is not there. I would request anybody to take this. This is just to complete the, when we were talking across the ages, so how the postmenopausal woman will be left behind, a 65-year-old postmenopausal woman presenting with just a single episode of vaginal bleeding. On per speculum, there is nothing, so it rules out a cervical vaginal cause. And uterus appears a normal size, they write. So what are your comments about the further management? Anyone who wants to take it, please.
Madam, can I?
Yeah, sure, ma'am. Yeah, sure.
The normal size uterus is not normal for a postmenopausal woman.
Correct.
So we should think of other things. When there is an endometrium more than 5 millimeters, endometrial in a postmenopausal woman, first we should go for an endometrial biopsy to rule out malignancies. And endometrium is more than 5 millimeters, it is a must. If it is thickened and irregular endometrium, we have to go for hysteroscopy. Actually, usually clinicians are prescribing an estriol cream for senile vaginitis. That might be the cause for thickened endometrium also, endometrium more than 5 millimeters. But depending upon the endometrial biopsy, we have to proceed for her. If most of the times it comes out as a endometritis, that doesn't need any treatment. Actually, endometritis, usually it subsides.
Maybe some antibiotic, maybe just give it.
Yes. Can I have a word? Can I have a word?
Yes, ma'am, please.
So it depends also on the comorbidities. We should exclude diabetes complicated. Diabetes, if she is a diabetic and obese, more than 30 BMI, we should also evaluate endometrium, chance of endometrial carcinoma or some other carcinoma with a polyp that changes into carcinoma should be evaluated and taken into consideration and treated.
Right. Thank you, ma'am. So, Dr. Aruna, how is the management now? I have talked about women all across the ages. We are going in through the pandemic era. So nowadays, how is it getting different, managing these women? You are having more of teleconsultations. What are the other things that you would like to highlight? There have been some guidelines also from some of the societies. So would you just like to tell how you are managing it?
Yeah, it is AUB in COVID times. It is a remote and online treatment. We have to take the detailed history of age of the patient, the duration of bleeding, how many pads she is wetting, history of amenorrhea and bleeding again, and history of taking any drugs like anticoagulants or irregular hormone therapy, and whether it is associated with pain or not, whether it is foul smelling or not, any similar past history is there, and whether she is having giddiness, breathlessness, of severe anemia, SID, and antibiotics if any infection is suspect. Then if you can go for naratriptylone tablets or metacipprogesterone estate.
So important point.
The dose is depending on the severity of the problem.
Yeah. So important point is that through the teleconsultation, we should try to understand that which are the cases who need to come to the hospital and which can be managed through the medical management, and we can prescribe that. So that is an important message, that people should try to take a detailed history. We cannot examine, but try to pick up the risk factors and, after, and follow them up after the medical management if they are responding or not, and then accordingly take a decision. Those who have a high risk of malignancy definitely should be called earlier to the hospital. Yeah. So this was,
They should come to the hospital.
Yeah. So this was one case I just wanted to share here. Last year when there was this second wave, which was the most deadly one, we had this endometrium patient I had, and she was a very high risk comorbidity. She was unfit for the surgery. And at the same time, the second wave came, and then I just had to, OTs were closed. So I just thought of putting in a Mirena at that time, and I put it, and 3 months later I operated this did not. So normally this is a treatment for fertility preservation in young women, but we just put it in that time. So that was just a small share that I wanted to make here, that you have to modify your things. And then when we operated, the disease was still located to the endometrium only. Just the findings were no worse than what we had on the CT findings before the putting in the Mirena, so rather improved. So I think that was all from my side. I tried to cover it in time. And thank you so much to the organizers, panel experts, and all the audience. Best wishes to Sadhna ma'am for her endeavor, and Dr. Manoj also is there contesting. So thank you so much.
Thank you, Dr. Nisha. Thank you so much.
Thank you, Dr. Nisha.
Thank you.
Thank you very much.
Thank you,
Thank you so much.
Thank you, Dr.
Organizers and Sadhana Gupta madam, all the best for your Foxy president elections.
Thank you, all the panelists and the moderator, Dr. Nisha. Dr. Nisha, I have a small doubt.
Yeah.
In the second case, you said a 22-year-old with oligo, with a less flow. We have to rule out COX, thyroid, etc., prolactin, etc. So for that case, endometrial biopsy is a must. And whether we have to go for endometrial biopsy along with hysteroscopy or blind biopsy followed by hysteroscopy, what is your stance on this?
So it is very simple that whenever we have to plan an endometrial biopsy, we'll do it after the transvaginal sonography. If the sonography shows a regular line endometrium, which is thick but not as thick, up to 10 to 15 centimeter, you can go for a blind endometrial biopsy also. Only when it is irregular or there is a localized thickening that you suspect that there is a lesion, which better will be taken up by visualizing it. And so that's how whether to go for and then of course your facility will make a difference, but when you have all the facilities, this is how we usually decide. So usually in these young women, infertility, infrequent cycles, usually the blind biopsy is also good enough with the pipple. It's only when there is irregular and localized lesion that you can see, then you should.
For cases of polyps and all, better go for hysteroscopic excision.
Yes, because it will be diagnostic and therapeutic. We have had arguments on this with some senior people also. They say that you just do a polypectomy, DNC, DNC, all the polyps. No, all polyps will not go. The bigger ones rather will never go. You will have a normal histopathology and you will think I've done, but then the treatment has not been done. So that's what.
Yeah. Thank you, Dr. Nisha, for moderating this panel. And this is an evergreen topic. It's the most common complaint by a gynec patient having bleeding disorders. Thank you so much for this wonderful panel and all the panelists also. Thank you so much.
It was a great experience, Thank you so much.
Dr. Padmaja, I would like to hear something from you.
Unmute yourself,
yeah.
Dr. Padmaja.
I've been enjoying the entire panel. The thing is, being in infertility, we realize there is so much more, like the ultrasound and hysteroscopy are like two eyes. So
Yeah.
it is like you're getting blinded. So sometimes the endometrium looks so perfect on ultrasound, and you go and see there are all micro polyps, it's shaggy. You go in and see, you think, what is it? And sometimes the endometrium looks so polypoidal, and you go in and see it looks normal. So we need complete information, because there is some element that is preventing this uterus from acting how it should and behaving exactly as it should. Because we're not looking at the gene profiling and the responsiveness there. So what we are seeing is the end result of all the abnormalities that are happening. And especially when with increasing PCOS, with increasing obesity, I feel there is a lot of impact on with our food and endocrine altering substances on the endometrium. So we should be more vigilant. So liberal use, it is better to be cautious than sorry.
Absolutely.
Thank you all. Thanks the panelists, because in spite of the COVID third wave, all of us in and out, positive, negative, different waves, all of you managed to do such a great job. So if we can go on to the next.
Thank
Can
you.
I have the, yes, we are having the next session where we are talking about the, as a continuation of what we've been discussing since morning, what about surgeries in the gynecology aspect? We have Dr. Ramani Devi here talking to us about the problems in adolescent. All of you know Dr. Ramani Devi, who's a brilliant student in her undergraduation and post-graduation with a tally of 10 gold medals, had IVF training in Israel, London, Mauritius. She has been a backbone of the Endometriosis Society of India. She was a South Zone Vice President, and it would take an hour to read up all Madam's credentials. But we invite you, Madam, and we are very happy to have you here with us. Dr. Ramani is there. She's logged in.
Yeah, Madam, she's there.
Yes. So, Dr. Ramani, the stage is yours.
Yeah, thank you. Thank you. Thank you, Dr. Padmaja, for your nice words. And congratulations to Vijayawada Society for having taken this topic. And I also thank Dr. Sadhana Gupta Madam, who has been, I think she was instrumental behind this program. Okay. So all the best, Sadhana Gupta Madam and Manoj Chellani. Okay, then, so today let me start on to the topic. It's a safe surgical strike in gynecology. When, how, and what next? That is specific to adolescent age. So I bring you greetings from Rock City and a happy new year, at least COVID-free year ahead. And now coming to the topic proper, what do you mean by adolescence? It's a transition phase that is between childhood and adulthood. Adolescence is the period of life an individual when society no longer views the particular girl as a child but does not yet concede him or either the roles or the functions of inherent in the state of adult. So WHO defines adolescence as any person between the age of 10 and 19. Okay, so then again, types of adolescence is 10 to 19 is quite a vast age. And here they have again, the ages has been described or by Corpus et al. In 2010 into early adolescent, that means age around 10 to 13, middle adolescent ages between 14 to 16, late adolescent that is somewhere beyond 17. So gynecological disorders are uncommon in pediatric and adolescent population. Those requiring surgical interventions are uncommon. Estimated incidence is around 2.6 cases per 1 lakh adolescent girls, and benign lesions are more common. 9 to 11% of adnexal masses in this age group can be still malignant. So the surgical conditions in adolescent gynecology are, see, we go back to DOS classification of congenital, traumatic, inflammatory, neoplastic, iatrogenic, not classified, and I have added pregnancy-related complications in adolescents. So the causes of gynecological disorders in adolescents are, to start with congenital, it could be Mullerian anomalies, neonatal cyst that occurs because of the maternal estrogen level, but that doesn't come under the adolescent, but still you can have existence of this benign cyst in adolescent girls, functional ovarian cyst, tubal, paratubal cyst, peritoneal inclusion cyst, hydrosalpinx, tubo-ovarian masses, and then abnormal uterine bleeding. The POM classification like polyps, leiomyoma, malignancy can still happen. Pregnancy-related problems like incomplete abortion, gestational trophoblastic disease, ectopic pregnancies, endometriomas, ovarian torsion, and adnexal torsion. Now, let us see how do you clinically approach these gynecological disorders. First thing is history. Then comes the symptoms. Then comes the physical examination. We know very well that physical examination has got a limited role in sexually inactive adolescent girls. So we have to mainly rely upon the imaging modalities and the tumor markers. So in the history, what are the things we are going to ask? Ask them about the presenting symptoms, the duration and the nature of the pain. Acute onset of sharp pain may represent adnexal torsion, acute abdominal pain that could even have because of mass effect, nausea and vomiting, secondary to pregnancy complications, or it could be even precocious puberty that can manifest with a form of vaginal bleeding. Cyclical discomfort in menstruating female may indicate endometriosis or Mullerian anomalies. Furthermore, adolescents should be asked about sexual activity, mainly to rule out pregnancy-related complications. Contraceptive practices, history of sexually transmitted disease, and the possible use of sexual abuse that has to be recorded. The symptoms of gynecological disorders in adolescents, sometimes it may be asymptomatic and incidental finding. That sort of presence is very, very common. Or the next one is it could be pain, any variety of pain, acute pain or chronic pain or acute intermittent pain. Then again, abdominal distension or effects of abdominal masses, then weight loss, polymenorrhagia, menorrhagia, precocious puberty, amenorrhea, dysmenorrhea, dysuria, constipation, leg pain or limb. They may be secondary to the mass effect of the abdominal masses which are formed. Fever, nausea, vomiting, and back pain can also happen. On physical examination, examination of the virginal pediatric patient may be limited, but abdominal palpation and rectal palpation examination can assist in diagnosis of these young girls. If more detailed physical examination is warranted, maybe an examination and anesthesia should be considered. In sexually active girls, pelvic examination can be done with proper counseling. A Q-tip test may be done to rule out Mullerian anomalies such as transverse vaginal septum, etc. So then coming to the imaging modalities, they are of immense help in diagnosing adolescent gynecological problems. By ultrasound, it is the ability to distinguish simple cystic structures from solid or complex masses are possible. Ultrasound can assist in discriminating adnexal masses from GI or uterine pathology. In additional imaging, if it is needed, maybe CT or MRI can be used. MRI is it has got a certain advantages over CT and ultrasound because it lacks ionizing radiation, and also the characterization of the lesion can be better marked out with MRI. And again, in suspected cases of Mullerian anomalies or rarely ovarian tumors, MRI is of much use. So next, coming to tumor markers. Of all the tumor markers, the commonest tumor marker that is being used is CA-125. It may not be useful in a simple ovarian cyst, and how far it can differentiate malignant from benign lesion, still we do not know. And again, we know that CA-125 is non-specific and it may be elevated in so many conditions. But again, if the level is very markedly elevated, see, when we say that the tumor marker, it should be less than 35. If it is increased beyond that, then we have to think about many conditions, especially endometriosis in adolescents, which is increasing in incidence we have to think about. And sometimes the levels can be even greater than 1000 units. In such conditions, One is we have to strongly suspect malignancy, or a simple rupture of endometrioma can also produce a very high level of CA-125. So if the level of CA-125 is greater than 200 units, it is always better to have a discussion with our gynec-oncology friends. So other tumor markers that are very common in germ cell tumors, because dermoids are very common, dysgerminomas are common in adolescent girls, we have to study the role of alpha-fetoprotein, which is markedly elevated in endodermal sinus tumor and embryonal carcinoma. Beta-HCG is elevated in choriocarcinoma, embryonal carcinoma, and LDH is in dysgerminomas. So now let us come to each one of it. The Mullerian anomalies affect 7% of the female population, and they may present with variable clinical features, like it can starting from amenorrhea up to progressive cyclical pelvic pain. It can occur, and there may be some obstruction leading to hematocolpus, hematometra, etc. Then there can be imperforate hymen, vaginal agenesis, segmental vaginal atresia, transverse vaginal septum, uterine didelphys with obstructed hemivagina, uniconnovate uterus with a non-communicating rudimentary horn or rudimentary horn. Then although MRI has been 100% sensitive and 83 to 100% specific in diagnosing Mullerian anomalies, laparoscopy is required to assess exactly what is the anomaly, and the corrective procedure can be simultaneously handled. So coming to imperforate hymen, which is one of the commonest conditions where the girl presents with primary amenorrhea, presenting with features of cyclical dysmenorrhea, retention of urine, and diagnosis is based on the clinical examination, where all of us know that there is a bluish vaginal discoloration with the hymen which is intact, and what it can be confirmed by ultrasound and a simple cruciate incision what we make in the vagina and drain the collected blood will be sufficient. But the most important thing I would like to add up is follow-up of these patients are very, very important, because sometimes it can be an uterine, because one malformation always you think about other malformation. I have come across a patient with uterine didelphys. Once she presented with imperforate hymen, I just did the hymenectomy, but she came back after some time, few months, with severe cyclical pain, and she was found to have an associated cervical agenesis in the other horn. So post-operative follow-up is a very, very important one. Then coming to Herrlin-Werner-Wunderlich syndrome, which is which is not a common one, but if you come across, the surgical correction always helps in it. Here there is uterus didelphys, where the obstruction can be at the level of one horn, that is either at the cervical level or at the vaginal level, and because of the obstruction the patient can present with features of hematometra or hematosalping. Ipsilateral renal agenesis can happen in this, and they are quite often associated with endometrioma on that ipsilateral side. So this is a patient where we had see, you can see the right side horn is filled with the fluid level, and you can see the hematometra. This was a girl who was 13-year-old, came with cyclical pain, and the endometrioma on the opposite side was there. Just a simple procedure of hemihysterectomy, because in these conditions, unification surgery becomes very difficult. And this particular girl, I operated her when she was 13 years old, and now I am happy to say that she has delivered 2 babies at the age of 21 and 24. So the next comes another variant, that is the Robert's uterus, where it is a very rare type of Mullerian anomaly, and American Fertility Society classification does not include this, but ESHRE ASG classification explains this as an anomaly with U2, U6, CO and VO. Diagnosis is quite often. This is again a particular patient where she had a right side hematometra, and the other horn of the uterus was quite normal, and she was started having a regular menstruation followed by severe progressive dysmenorrhea. So with this, this was the 4th surgery the patient has undergone, because the previous surgeon has removed here the right tube and the right ovary. because she found that there was a endometrioma. Again, when the pain persisted, the second surgeon thought that it could be because of additions. They had done an adnexal, but ultimately it was an atypical septum which was found out, and just a simple septostomy where you can make the content of the right horn drain into the left horn. So then following this, so this was the picture. So where you can see the initial picture where the bulging of the right side was seen, and this was post. The third one video was the unification, that is after septostomy. This video was taken after 2 months, and the patient has a single uterus. I mean that the septum is being taken off, and now the patient is completely pain-free. So then coming to the next one, that is trauma. Injury is again a very common one. These children, they can, during adolescent period, during playing or anything, they can have this hematometra, or which can even which can be treated accordingly, whether it may need a surgical excision or you can just conservative management. And next comes the rape, that we have to be very, very careful, because any injury in the anal or in the vaginal region, we have to think about rape. So again, another one is foreign body in the genital tract. The commonest foreign body, in young children, it is very common, but even in adolescent, the common one is the foreign body is the tampon, that is left unnoticed or forgotten tampons that can cause foul smelling discharge, or sometimes the toilet paper or slate pencils, etc. So that can be removed either by hydrotherapy or vaginoscopic method using hysteroscopy. You can remove it. So then comes the functional ovarian cyst, that could be because of the hemorrhagic corpus luteum, and it can form loose adhesions and thin wall septation. And the treatment is mainly these patients are asymptomatic. Follow up the patient. Sometimes giving combined oral contraceptive pills can reduce the fluid cyst size. So unless the patient has got severe pain or when there is a torsion or bleeding, laparoscopy is generally not indicated. So this is the hemorrhagic cyst, again, which can cause acute or chronic pelvic pain. And most often these sort of cysts will regress with the cirrhosis. Then paratubal and tubal cysts, they are incidental findings, and they are all remnants of the paramesonephric cyst. And unless the patient is symptomatic, they need only follow-up, and they do not need any surgical intervention unless there is rupture or torsion. And isolated tubal torsion is quite very rare. So this is a patient where she came with the torsion of the left tube is there. So you can see the torsion of the left tube. At the same time, she has got endometrioma of the other ovary. So this her main complaint was only severe pain, cyclical pain, and intermittent torsion of the tubal thing had also given her intermittent pain. So simple correction of the torsion can relieve the pain. So other one, this is a young girl where there was quite a big broad ligament cyst. This was a 16-year-old girl who came with came with complaints of intermittent torsion. So this patient had got a ovarian cyst which was quite large, but on putting a scope, we found out that it was a broad ligament cyst that has undergone intermittent torsion. So this simple excision of this broad ligament cyst will be sufficient. At the same time, when you are doing the procedure, be careful that we are not disturbing the tubal anatomy or causing any tubal injury. So then the peritoneal cysts. Peritoneal cysts are loose cysts that occurs because of pelvic adhesion secondary to impaired absorption of the peritoneal fluid, and invariably they are post-traumatic, and such scenarios we can see in patients who have got a pelvic infection which could be secondary to tuberculosis. Then comes the hydrosalpinx. Occasionally these hydrosalpinx in these young girls could be secondary to tuberculosis, and it usually appears as a fluid-filled structure, that is a sausage-shaped structure. And the main treatment, it can get, it needs a surgical correction if there is persistence of pain, or suppose if the patient gets married, maybe for infertility management, we need to correct the hydrosalpinx. Then tubo-ovarian masses in adolescents, they can also happen secondary to pelvic inflammatory disease, and the symptoms often 19% of the adolescents are diagnosed with pelvic inflammatory were found to have tubo-ovarian abscess in the ultrasound, and they have typical systemic signs like fever, leukocytosis, abdominal pain, cervicitis, and discharge, and very often they appear as a thick-walled masses. And this was a patient who had undergone endometrioma for an adolescent age. She was an 18-year-old girl, and following endometrioma excision, she came to us with complaints of severe pain and fever. And this was the picture. Laparoscopy showed that it was an tubo-ovarian abscess, and all this tubo-ovarian abscess, unless we are going to correct it, drain it surgically, the pain is not going to get relieved. So then we need to follow up the CDC guideline for tubo-ovarian abscess. Then the other situations are in adolescents are AUB because of polyps. Then this is a fibroid polyp. That these were all young adolescent girls at the age of 16 to 18. So this simple polyp, fibroid polyp, this could be removed. And again, you can see another small fibroid polyp inside the cavity. So these things can be picked up by ultrasound, confirmed with ultrasonogram, confirmed with the hysteroscopy, and we need to remove it. Simple DNC may not be sufficient because these polyps are sometimes what happens is you cannot remove the polyps by a simple DNC. So sometimes, rarely, endometrial hyperplasia or even atypical endometrium with cancer of the endometrial carcinoma can happen. And this was a patient who had the third video was a video of a young girl. She was 20 plus because she was having continuous bleeding PV right from the age of her menarche. She's a known case of bilateral polycystic ovarian disease, and she was found to have multiple polyps. On doing hysteroscopy and removal of the polyp, she was found to have a grade 1 well-differentiated adenocarcinoma. So always don't think that irregular bleeding in adolescent age needs only medical management. Sometimes you have to put in the scope and see what it is exactly, because simple polyps cannot be removed just by DNC. Again, incomplete abortion, missed abortion, gestational trophoblastic disease can happen in adolescent girls. And once if they are not married, it is always advised them to have for a proper contraception in the follow-up. Then ectopic pregnancy is another common condition where I am sure that many of us would have seen this in young girls who are sexually active, and most of the people, most of these young girls, if they are not married, they may not reach the doctor at a proper time, and they are seen invariably with the rupture ectopic. This is a patient, 19-year-old girl, sexually active, and she came with a severe abdominal pain, and she was found to have a rupture ectopic on the left tube. So always think about ectopic pregnancy also, especially when the patient is pale and she has got severe abdominal pain, whether she is married or not. First thing is you have to rule out. Then comes the endometriomas. Endometriomas in adolescents, to be frank, that we are off late getting a lot of girls, young girls with endometrioma. And the most important thing is, see, the medical management should be the first line. Dynegest is an ideal drug, or if the girl is beyond 16 years, maybe GnRH analogs can be given. But there are situations where you need to go for surgical correction also in young girls. So these are all young girls, the laparoscopy of young girls, where the second upper one, you can see the rupture. So at the background, we can see the endometrioma. And here, this one, the third one is a young girl, that is again a 19-year-old girl, medico, where she was found to have, she was treated on Dynegest, but persistent pain that was preventing her from attending the classes. So in such situations, maybe the failure of medical management, we need to go for a surgical correction. And especially when it is associated with Mullerian anomalies, go for a immediate surgical correction. But the most important thing is, after surgical correction, these patients have to be followed up with some form of medical management. So this is again a patient with the complaints of rupture. This caused again an young girl where there was a rupture and the CA125 level was beyond 2000 units. So they had actually referred the patient as a malignant ovarian, but the history gave the clue that the progressive dysmenorrhea in that particular girl gave the clue that she was having a ruptured endometrioma. And after cystectomy, bilateral cystectomy, the patient has been put on Dynages and continuous oral contraceptive pills. And now she is almost 4 or 5 years since the procedure was done. And she is remaining symptom-free. So this is the algorithm for adolescent endometriosis. We have to start with NSAIDs, then oral contraceptive pills, Dynages, and sometimes GnRH can be given. And if the pain is relieved, then follow up the patient. Otherwise, if there is continued pain, maybe we need to go for a surgery. So cystic teratomas are another common condition because they also occur in a young girl, and bilaterality is very common. So this is a case of laparoscopic excision of a dermoid cyst where bilateral dermoid cysts are there. One thing we have to understand is the ovarian reserve is not altered in this dermoid cyst, but whereas ovarian cyst are the AMH levels are very much decreased in patients with endometrioma. So again, dermoid cyst, the management is only surgical management because at times the chances for torsion of the dermoid ovary that contains the dermoid is possible, and always try to rule out that bilaterality is not there. And this particular patient did well, and this was the final view of the patient. So then cystadenomas, simple cystadenomas can happen, and you can start them initially with few cycles of oral contraceptive pill, but if they are not responding, or if the size of the cystadenoma is greater than 7 or 8 centimeters, always it is safe to go for a surgical excision because there is always the risk of torsion of that particular ovary. Again, when we do a proper surgery, there may not be any loss of this antral count, and only the cyst wall excision can be done. And ovarian torsion is also again common in females up to the age of 20 years, and it is estimated to be 4.9 per 100,000. And initially, whenever there was symptoms of ovarian adnexal torsion or ovarian torsion, they present with systemic symptoms and pain, nausea, severe abdominal pain. Sometimes intermittent pain can be there whenever there is an intermittent torsion. And the typical whirlpool sign is seen in the ultrasound, and the imaging, either an ultrasound or a CT or an MRI can help it. And the management of ovarian torsion is invariably these girls, they need a laparoscopic correction. You need to detort. So when we are doing a detorsion, you wait for some time. What happens is the detorted ovaries may regain their vascularity, and maybe after a few days. So this was a case of a 14-year-old girl where she came with an adnexal torsion, and the entire ovary was totally gangrenous because the girl was having almost symptoms for a period of more than a week, and we could not save the uterus, save the ovaries and the tube. It has got torsion, it has undergone torsion for many times. So that this was another patient where the detorsion, and after 3rd day of the laparoscopy shows that the ovary has regained everything. So now with the recent trend, there is always a place for detorsion of the ovary. Wait for some time, the ovary can regain their vascularity. But there are instances that sometimes we need to go ahead with salpingo-oophorectomy in conditions what I had showed earlier. Isolated tubal torsion can also happen, and then the diagnosis and management of adnexal torsion in adolescents in the pediatric age group is go for a transabdominal ultrasonogram. See whether the findings are suggestive of adnexal torsion. You have to go for a diagnostic laparoscopy. If there is no suggestion of adnexal torsion, maybe you can wait. If pain resolves, observe the patient. Otherwise, if the pain is persistent, maybe we need to go for detailed investigation. So what you do in management of adnexal masses in this adolescent girl is always a laparoscopy is preferable to a laparotomy or a mini laparotomy. Malignant lesions are also can happen in 4 to 9% of the cases. And whenever we do a surgery for malignant lesions or treat them, fertility preservation has to be considered in these adolescent girls. So this was a patient who was posted for laparoscopy for suspicion of multiple endometriotic cysts. But unfortunately, this turned out to be an endometrioid carcinoma, and hence we just came out with a biopsy, and later this patient, because of its bilaterality, patient has to undergo a staging laparoscopy. So ultimately, the tips for laparoscopy in adolescent is bladder is intraperitoneal, be careful. Then thin child, aorta is just below the skin. We have to be very careful when you are putting the primary trocar. Pneumoperitoneum has to be set up at 12 to 15 mm for thin adolescent, and for a younger children even younger than that. So another thing is, when you are putting try to when you the port side herniation has to be avoided because the fascia are thin, and you try to close it properly. And then avoid vaginal manipulation, and always be mindful about the effect of intraperitoneal carbon dioxide under pressure because of the limited functional capacity, and anesthesia has to be very careful. So this is the last flow chart, where whenever there is a girl presents with the ovarian cyst, asymptomatic pain or menstrual problem, precocious symptom, can do a ultrasound. Then first, if you think that it is a simple cyst of 3 to 5 centimeters, just wait. Again, or if it is beyond that, if it is asymptomatic, we can follow because it might resolve. If it is beyond 7 centimeters, or if it is symptomatic, then maybe you need to go for a laparoscopy. So in conditions of acute emergency, you have to suspicion of torsion. You can always think, take the help of the tumor markers, and if the tumor markers are elevated, maybe we will need a gynecologist. To conclude, adolescent gynecological conditions needing surgical interventions are rare, but we need to think about them. Most of them are benign. USG and MRI are the diagnostic aids. Early interventions are needed. Laparoscopy is better than laparotomy. If surgery is performed, technique of ovarian preservation has to be prioritized when benign lesions are encountered to optimize future fertility potential. Conversely, when malignancy is identified, a collaborative approach is needed. Adolescent interventions at a proper time may prevent major gynecological problems in future. And education is the most powerful weapon which you can use to change the world. So I thank you for giving me this opportunity to say a few words about my ideas about this adolescent surgical problem. And this is the beautiful temple of Sri Rangam, which has been UNESCO approved, and the Rock City. Thanks for the opportunity.
Thank you, Dr. Ramani Devi. That was a wonderful presentation. You've taken us through the entire gamut of from adolescence to adulthood, and from conservative to, it was like an IAG conference with all the endoscopic surgeries being shown. Thank you. Thanks a lot, madam.
Thank you.
Dr. Ramesh, who was supposed to join us, unfortunately had an emergency and could not join. So I thought we will use this opportunity to ask Dr. Sadhana Gupta, who was our campaigning for the presidential candidate. Wishing you all the best, madam. Madam, would you like to comment on in infertility? What are your thoughts? Basically, it will be a continuum of what Dr. Ramani Devi was telling, but Dr. Sadhana Gupta?
Yeah, madam, she is there.
Madam is there, but she is
she must be on another phone or something. So what...
Padmaja, we can discuss, Padmaja. See, what are the things we need to look into it in adolescent girls where you need preservation of fertility. That's all. So main thing is always measurement of anti-Mullerian hormone is a, madam has come. Measurement of anti-Mullerian hormone is a must when we are dealing with ovarian masses in adolescent. That is one thing. And again, when we are doing that, I have already explained in endometrioma, it gets affected and we have to be, the first surgery should be the best surgery and it should be done by the senior most consultant. But other simple cysts or dermoids may not have any impact upon the anti-Mullerian hormone. And sometimes we need to think about this fertility preservation, either a oocyte preservation or embryo preservation when you are dealing with cases with endometrioma or malignancy.
What I tend to see is, madam, when the endoscopic surgeon you call, like sometimes the gynecologist might not be doing the endoscopic surgery herself, but when you tend to call the surgeons, we should be very alert and we should be the advocate for the woman, because whenever they say a big thing, they say, madam, the rest of the ovary is destroyed, let's do a salping oophorectomy. So they're very liberal with oophorectomy. So I feel that we should be, because as madam has shown, it was a bilateral dermoid, but also doing an oophorectomy is very simple, but that careful peeling will let the ovary come back to an almost absolute normal shape, where it cannot distinguish that this had those huge dermoids. So yes, whatever it is, doing a careful oophorectomy and preserving as much as the tissue as possible, not reaching and using cautery at the hilum. I feel that is
yes,
one of the things.
That's the most important.
Getting into the correct plane, not using cautery blindly will lead to a lot of tissue preservation. Dr. Sadhana, unmute yourself, please. Yes, madam.
So, actually, I was just in one overlapping talk, and because we are really, Dr. Ramesh could not join us with a very important talk. So I think that we will give 2 or 3 messages, because to have the completion of talk. So why take the safe surgical strike? Because a surgical strike, it can go anyway. And we should be one message which I want to give, that in infertility, because there are the 2 ways. Once the enthusiastic endoscopic surgeon, and whenever they see something and they have an itch to remove it and itch to put laparoscope into it. But all over the world, with the emerging interest in surgery and endoscopy, we are actually in what we say the tide wave for the surgery in infertility. So we should be very careful before opening up, before doing any surgical procedure. 2 things. One is the fibroid, where there is an issue when to operate in infertile women or not. So 2 or 3 things. Submucous myoma, we have to operate, whether you have to do the hysteroscopy, whatever it is, because it is obliterating, it is impacting the endometrial cavity. Still, the FIGO says now that you give 2 to 3 months prodinogest and this mifepristone, and see that there is a cavity obliteration is less or not, and then you can see that you can go for the routine infertility treatment. Even in submucous myoma, the FIGO and the ASRM new statement says like that you can try medical treatment and see what happens, that cavity has reduced in size. Interstitial myoma, if it is not obliterating endometrial cavity and not doing tubal blockage, need not to be disturbed. And likewise, the subserous myoma, better to ignore it. Only the large size myoma, more than 6 to 7, or they are having any pressure symptom, then we should go for the myomectomy. And myomectomy should always be, like we say, when we touch it, don't disturb the endometrial cavity, because we really see a lot of Asherman syndrome, because the after surgery myoma has gone, but a totally resistant picture has come, like a Asherman syndrome and the endometrial synechium. So I think for fibroid, either ignore it or treat it. Medical management is justified through today's professional body, even in infertility, to see that what happens, and after 3 or 3 months of the medical treatment, you can go for the natural ovulation induction and IUI, what next. And you have to be very, very careful that don't disturb the endometrial cavity. Second is endometriosis. I think it has been taken well by the Dr. Asha Rao and then Dr. Ramani. Endometriosis, again, we have come a long way ago, and the surgery strike, simple indication.
if it is adversely affecting your follicle pickup or the follicular ovulation stimulation, or it is a gross distortion of tubo-ovarian anatomy. And large myoma, for the pain, there is associated pain, patient is not able to tolerate, then this is the time to touch endometrioma. There is a definite technique for it, that we should preserve ovarian reserve. We should do cystectomy, not to do the aspiration and ablation, which cause recurrence very, very quickly. And we have to be very, very careful to maintain the vascular supply. For all the medical, legal, all issue, we should do pre-operative AMH and we should do the post-operative AMH. In deep infiltrating endometriosis, especially, it is very, very painful and we want to do surgery, but it is DIE which has got a highest complication rate because it is going into the bowel and the rectum. So cystectomy, very good, maintain vascular supply, do all the things so that the ovarian reserve is maintained. Sometimes we do pick up first and then do endometric surgery, and then we do the freeze embryo transfer after the surgery. That is also an option. But the most important indication for surgery is when you are doing ART, then it is coming into the way of the follicle pickups and patient is having pain and the size. So endometriosis is this about, and the long standing down regulation is the preferred way. I think Dr. Ramni will agree that 3, 4 to 6 months of GnRH analog followed by the ovulation stimulation that suppress the endometriosis, and then we have a good stimulation. So be very, very careful and don't frighten everything that we will do surgery, because after surgery also we are nowhere. It takes a long time surgery, then we wait, then we do the ART, and that also increases the cost and everything. The Adnexal mass self-injectomy, I think I have covered in my talk also. When there is a ultrasound detected hydrosalpinx, then before ART, it should be removed. And if there are a very, very dense perilital adhesion, occlusion. Because actually we must know everything. If we say only self-injectomy, and if there are so many adhesion, then we have to be flexible what is best for the patient. And if it is asymptomatic, patient is completely asymptomatic and fine, then we should not touch the thing. It is on the ultrasound, not detected hydrosalpinx does not need any surgical correction. I think, and the fourth thing is the laparoscopic ovarian drilling, which we do for a very, very select group of PCOs who cannot able to follow up in very high LH, especially who cannot afford the IVF and the very close follicular monitoring. Be very careful. It is 4.40 watt. Always do the good thermal irrigation after this laparoscopic ovarian drilling, and use this is not should be that you put laparoscope and use it. Let's do the drilling also when we have put the scope. It should not be the day. It should be pre-planned for a very, very selecting. I think this is hydrosalpinx, endometriosis, and the fibroid. These are the 3 key issues where we do any surgery, but plan surgery, hold your thought, don't push into it, give the patient 1 or 2 or 3 minute time. Many asymptomatic myoma, even with the 4th. That's why we are doing so much of cesarean myomectomy, because patient with fibroid conceive, so that we have that workload that we do the cesarean myomectomy. So it is a safe surgical strike in infertility, and infertility, it is really taxing to women. Everybody says, what is happening? We don't have a child and it is a surgery, and their concern are very much right. I think I have given 2 or 3 key points to the best of my capacity, and we are missing Dr. Ramesh because of emergency, and I think we can have comment from Dr. Ramni as well, and if Dr. Asha is there for any add-on comment on infertility, surgery in infertility.
One more thing I feel, madam, is when a laparoscopy is definitely indicated and we are doing it for infertility purposes, completing it with a hysteroscopy is very advisable.
Yes.
So because you can't ask her of the people who have fertility issues, different studies show, even with a good ultrasound, which shows absolutely nothing wrong. There are studies with as has 15 to 35% of intrauterine abnormalities being picked up, at hysteroscopy. So adding that another, the procedure as such takes another 10 minutes, but adding that value will be a good thing for the patient because it will be a comprehensive thing. Ultimately, whatever is done, the implantation has to be in the uterus. So we need a good cavity and subtle small polyps, a little amount of chronic endometritis, a little sticky endometrium. These are the things that you will pick up only on a hysteroscopy.
Perfect. A laparoscopy you're doing, you always do, because this is the thing we omit with the surgery and we don't know anything. It is another anesthesia, another patient appointment, another expenses. So always to be there, and it gives you a complete picture of the patient as well. Actually what we are, and always in our setting, we do PCR for endometrial tuberculosis histopathology, and that scratch also lead to the some, like what we say now, all the anti-inflammatory cytokine and all things. So it helps also. So wonderful. Always combine hysteroscopy and laparoscopy. So,
shall we close the session, madam?
Yes. Thank you. Thank you, Dr. Selja. You've done, as usual, an excellent job.
Thank you, ma'am. First and foremost, I thank Dr. Sadhana Gupta for giving Vijayawada Society the opportunity to do this session. And we from Vijayawada Society wish you all the best in your future election and future endeavors. I thank the chief guest, Dr. P.C. Mahapatra, who could not make it today, and the guests of honor, Dr. Sharda Jain and Dr. Ambuja, for spending their valuable time, and our guiding person, Dr. R.S. Ramadevi Garu, for giving us the opening remarks and her useful advice. I thank all the 4 chairpersons, Dr. Padmaja, Dr. Lata, Dr. Indira, and Dr. Susila, for helping me run this session. And I thank all the speakers and panelists for their valuable inputs and sharing their knowledge and their experience with us. Dr. Ramani Devi Garu, Dr. Asha Rao, Dr. Manoj Chellani, and Dr. Queen Aditya, and all the panelists from all over Andhra Pradesh. I thank ICOG for their credit points and the AP Medical Council for the credit hours, and AP Medical Council observer Dr. Hemabindu Palatla is still logged in with us. Thank you, madam. And last but not the least, thank you, Shield Healthcare people, Nishant, Tulika, Chitrakala, Bharat, everyone for the technical support and the coordination.
Thank you, ma'am.
Which helped us run this session. Thank you, everyone.
And thank you, Sharja. You are such a proactive, like the Secretary, Dr. Geeta, Dr. Ramadevi, and you know, we called many, like you are perfect organizing, respond well, work well, coordinate well. It is great to have you, and
thank you, madam.
All the coordination. So
wish you all the best.
Thank you and Dr. Geeta and Dr.
Thank you from all of us, ma'am. Sharja, madam, to you too. Thank you, ma'am.
Thank you. Bye-bye.
Madam, all the best. All the best.
Thank you.
And
all the best, ma'am. All the best.
Society, very good work you have done. And I remember the days when I was there physically with Vijayawada Society.
Yes,
that was a memorable thing. I had visited the temples there, and it was a very pleasant memory.
It was great to have you and Dr. Sampath Kumari also.
Yeah, we both were there. Sampath and me were there.
Yeah, those are the good old days, madam. Hopefully by this year
they will come again. They will come again.
Sure.